Medical College and GOVT.RAJAJI, GOVT.RAJAJI Hospital, Chennai. He is one of the doyens of nephrology, and he is a proud 1984ian. Venkatraman did MBBS from 1984 in Madurai Medical College. He did MD in Madurai Medical College under Dr. N.K. Unit and went through very tumultuous times. And he did DM nephrology from Madras Medical College, and he has established he is several firsts to his illustrious career, and he has been a member of transplant board, and he is conducted the maximum number of transplants in government hospital, in GOVT.RAJAJI Hospital, and he is a postgraduate teacher, and he has trained hundreds of nephrologists, and he has published several papers and delivered lectures in national and international conferences and symposia. Now over to Dr. Venkatraman.
Thanks, Alagappan, for a nice introduction. I say good morning to all our medical colleagues. Thanks to Tamil, Alagappan and Sundar for organizing such a nice event. I am here to present not the routine renal transplant. This is ABO incompatible renal transplant, what we have our experience in government setup. In government hospitals, we don't do usually ABO incompatible transplantation. That is when I was doing post-graduation. When the blood group doesn't match, that we usually say it is a contraindication. But after many experimentations and private hospitals started doing ABO incompatible transplantation, we tried in Kilpauk Medical College and Rayapeta Government Hospital, and this is only to show our small experience. So we did from 2017 to 2023, of course 24 data is still there, 26 ABOi incompatible transplantation. What we do is a baseline hemagglutinin titer, then followed by our most common blood group incompatible was B2A. All patients, they will receive rituximab intravenously 14 to 21 days prior to renal transplantation. All patients, they receive plasmapheresis for antibody removal. So we did one patient immunoabsorption. And for our induction, ATG and besiliximab were used as induction agent. And the results were 75% of the patients showed immediate graft function, and remaining had delayed graft function. I think as a medical student, we were all aware that we have to give induction agent, immunosuppressive therapy, other things. So this is our statistics. In 2020, we started in Rayapeta after the experience in Kilpauk Medical College. So this year, from 2024, we did again 3 ABOi incompatible transplantation. The statistics is up to 2023. So this is the latest IJN, Indian Journal of Nephrology data. The renal transplantation required as per the statistics in India is nearing 2,20,000. But only throughout the India per year, we do only 7,500 renal transplants. But if you take ABOi incompatible transplantation, it's only 200 to 250. So these are the centers in India, they are doing ABO incompatible transplantation. First in Chennai, they started in Mayat Hospital and Medanta. Are these centers they show varying results of survival from 87 to 100%. So these are the biopsy findings after renal transplantation.
So acute cellular rejection, tacrolimus toxicity, acute tubular injury, graft pyelonephritis. But in our patients, we have not reported any antibody mediated rejection. So other complications that were noted were acute gastroenteritis, pneumonia, graft pyelonephritis, and clinical malaria were seen in one patient. The graft survival was 90% and patient survival was 85% during follow-up of median 30 months. So this is the Rayapeta statistics. So obviously shows that from 2020, dialysis population has almost doubled from 6,000 to 12,000 and OP strength has doubled. So everything is doubling. The renal failure population is slowly increasing and we need to do something for these patients for permanent remedy of this thing, because dialysis doesn't give the quality, though it may give the quantity of survival. The quality of the patient is improved by renal transplantation. Of course, cadaver DDRT, disease donor renal transplantation, is picking up because of Transplant Society and Tamil Nadu program. So during this period, we have 2023, we have done 2 ABO incompatible transplantation and total live renal transplantation was 9. So we were second. RGGH did nearly 65 transplantation. KMC and Rayapeta did 45 transplantation in the year 2023. For this we were awarded best transplants prize in KMC and Rayapeta. Our surgeon Periyasamy is very notable for renal transplantation. He is an expert. So this is our transplant team along with Dr. Bala Subramaniam, and he is also a professor, and all our faculties, they work 24/7 when the cadaver comes, alert comes on organ retrieval. 2 to 3 days they will not sleep. So we don't see the duty hours in nephrology department by routine practice. So this ABOi incompatible we have presented in MGR University Medical Conference, which was also well appreciated. He is Professor Muthu Sethupathi. He is one of the doyen in nephrology. He is my teacher, and he has done the first renal transplant in Rayapeta Hospital in 1987 in government setup. And he has also made all government employees, wherever they do renal transplant, to receive all the immunosuppressant free of cost. Those days, cyclosporine used to be called as liquid gold. And our faculty receiving the Tanker Award, our student receiving in 2022 Dr. MGR University Gold Medal. So this is the Rayapeta team. We require a robust team to deal with even one single cadaver renal transplant or ABO incompatible transplant. Of course, in routine transplant, it is normal affairs. So this is our director Mani, who has supported our Rayapeta Hospital to the extent of from 2011 I am there 14 years. He has supported and given consumables to the extent of 7 crores. I should be thankful to him. He is Dr. Shivashankar, who is one of the best expert in Chennai available for renal transplantation. So coming to the topic, if you see a patient with a B who has only option of donor A, so what is the available option now? In our setup, he has to wait by registering in Transstan and wait for 1 or 2 years. In some centers it is even 2 years. Living donor pad exchange, that is, if you have a one patient with BA, another patient has A to B, you can exchange by getting approval from the transplant authorization committee. But this is happening in private hospital, but in government setup still it has not been accepted, because one, if we have to do it on the same day for both pair, but if one pair picks, another pair fails, then it is very crucial, difficult to face that situation, especially to our population who are coming to the government hospital. So I think we are constantly speaking to the transplant authorities, instead of going for ABO incompatible, which is very costly affair, why can't we go for donor organ pad exchange program, which was previously called swapping the kidney. Third option available is ABO incompatible transplantation. Fourth is unrelated, which is not our topic. So, what is the blood group in general? Commonly it is the O. Throughout the world, A is common, but in Tamil Nadu it is 29% B and 25% A. So in any renal center, you will see 35% of the people will be incompatible. So this is the blood group A. You have A1, A2. So what is creating the problem is the isoheme agglutinin. The antibodies are naturally present in the patient. So blood group A has two subtypes, A1 and A2. The antigenic expression of A2 is lesser than that of A1. So the overall immunogenic risk of is like this: A1 greater than B and greater than A2. So if A2 has low titer, I think we can do the transplantation without any desensitization. So what O blood group? It's the most dangerous blood group when we compare with the, though it's a universal donor, regarding the renal transplantation, it's the most dangerous blood group, because the heme agglutinin H antigen, which is formed even before this O group, is very highly antigenic. And you have both anti-A and anti-B. The person who has done along with the ABO incompatible transplantation with O blood group is likely to have higher percentage of antibody mediated rejection. So this is a B blood group. So historically, in 1955, after the initial episode of renal transplantation, which is done by Joseph Murray, the people requiring renal transplantation were on increase. So what they did, as usually in Westerns, they do straight away some 10 or 20 procedure, like CABG in Framingham study. After 1 lakh CABG, they found it is an useless procedure. Even medical treatment is better than the Framingham. Like that, this man did 10 ABO incompatible transplantation, then he just stand back, 8 graft is already gone. So in 1960, again Starzl, who is a notorious, is a very great scientist in renal transplantation, he has again done ABO incompatible, but overall very poor results. So in my up to my post-graduation period, ABO incompatibility was considered as absolute contraindication to kidney transplantation. So what made a breakthrough? In Japanese, they did a revolution. If you see, the naturally ABO incompatibility is happening because in pregnancy, that is, a mother of B can have a natural graft of fetus as A. Even in that, a O group mother who has a B or A group fetus is likely to develop more reaction, but that is mostly very minimal one. So how the nature handles? The placenta doesn't allow IgM into the circulation of the fetus. First point. Second, pregnancy is a immunosuppressive state. That is, as evidenced by the minimal change disease will go for remission in pregnancy, and sometimes lupus will go for remission, And pregnant patients are more prone for miliary tuberculosis during pregnancy as well as during the postpartum period. So pregnancy itself produces per day up to the amount of 60 milligram per day of steroid. Third point is after delivery we know, RH we know, because but major blood group also crosses the fetus. If B to A crosses, A to B crosses, there will be very minimal reaction, minimal hemolysis. But if the O crosses to the fetus, sometimes you can develop kernicterus. But this process of accommodation or adaptation naturally happening, nicely done by the nature, we have to do it in these patients. That is removal of antibodies producing cells by splenectomy and remove the already existing natural isohemagglutinin by plasmapheresis or immunoabsorption. So Japanese, they did from 1989 to 2001 441 patients with excellent results. So this is the latest IJN, which shows the protocol that is being practiced in Indian centers for ABO incompatible transplantation. That is after everything is explained to the patient, getting the committee approval, we get a date from the surgeon. So day minus 14 we give a rituximab. As you know, it is an anti-CD20 chimeric monoclonal antibody which depletes the B cell. If you give rituximab, you will not see B cell in the periphery for at least 3 months. Day minus 7 you start tacrolimus, which is it's a routine protocol, and 2 to 3 plasmapheresis will be done to reduce the titer to the level of 1:16 of the isohemagglutinin. Meanwhile, we will do routine T cell cross match and DSA, donor specific antibody. On the day of transplantation, I usually give basiliximab, though many centers they practice ATG, but which is a more powerful immunosuppressant. Day 7 he is again started with mycophenolate mafetil, which is a derivative of azathioprine. On table we give basiliximab and pulse steroid. So throughout the year we have reduced. When my post graduation period we used to give 1 gram, now it is reduced to 500 milligram. Day 2 250, after that it is converted to tapering dose of steroids. So after doing transplantation, post renal transplantation will do on demand antibody depletion. That is, post renal transplantation we have to carefully monitor. Routine renal transplantation we need not to bother, because the only marker for good graft function will be serum creatinine. But in ABO incompatible transplant, if slight graft dysfunction happens, we have to measure the antibodies, that is anti-isohemagglutinin. So these are the target titers. In our Indian setup, we usually, in West Bengal they make 1:30, but Indian protocol is less than 1:60. We also follow this in KMC and Rayapeta. The moment the titer reaches less than 1:60, the patient is transplanted. So the test is done by gel column agglutination test. So this is the ABO in desensitization and renal. First point is remove the ABO antibodies by methods which I will explain. Then immunomodulation, FFP or IVIG. I don't give this IVIG. Depletion of B cell population by rituximab and regular tacrolimus, that is CNI, one anti-metabolite, one steroid, that is routine immunosuppression. So immunoabsorption, it reduces the antibody titer very effectively, but it is very costly. The glyco-absorbed hemoglobin, which column, which we did for one patient, for one session it cost 2.5 lakhs. And of course we have to pay through our KMC GORH Nephrology Alumni Association. So we could not get it through CMCHS. So this is the immunoabsorption. See, the glycoabsorb is general column is also available, and specifically group A and B is also available. The point here is there is no wastage of any plasma or everything. We don't require any replacement solution, because as you all aware, when you do plasmapheresis, you have to give replacement like FFP or albumin, which again increases the cost. So this is the immunoabsorption which our patient, first immunoabsorption, the titer was more than 1028, and the patient was successfully transplantation. We again did one pediatric transplantation with the help of director. We have got a CRRT machine, and dialysis unit is installed in IMC also, because mostly CKD patients, they have developed pulmonary edema in the night. So double filtration plasmapheresis is the, we don't follow this procedure. Here you have a plasma separator and a plasma fractioner. The problem here is you will waste a lot of IgG and IgM fraction, that is discarded. So patient will have more immunosuppression. This is a fixed dose plasmapheresis. In some centers they do fixed, that is they do 4 plasmapheresis, give rituximab, and do transplantation. But we don't practice this. We do extra plasmapheresis till the concentration, that is dilution, reaches below 1 in 16. So in plasmapheresis you have plasma filters our government provides thanks to our CMCHS, and the replacement solution we usually give to reduce the cost ringer lactate. But if the session extends beyond 3 to 4, we give albumin or FFP, and the plasma here is discarded. That is the greatest disadvantage, because the immunosuppression will be more and you will be losing lot of coagulation factors. So replacement fluid, as I said, crystalloid, albumin or FFP. So we aim the target titer will be less than 1 in 16. So this is the comparison. So immunoabsorption is always better, but it is highly costly. The rituximab, so a chimeric molecule. Previously, when I was practicing in 2004 and all that, we used to give 500 milligram. With that dosage, that is 375 milligram per meter squared was the prescribed dose. But with that dosage, patient usually develops many infections and tuberculosis. So slowly Indian guidelines for our tapered to our patients to 100 to 200 milligram 2 weeks prior to transplantation. Plasmapheresis if required. If required means if you do A2 to blood group A2 to other blood group, if the titration is lesser, we can go ahead directly. And all induction therapy combined with rituximab, that is ATG. I don't give ATG, but basilicimab, which is an anti-IL-2 receptor non-depleting antibody. The increased risk of infection as well as the posterior leukoencephalopathy should be explained to the patient, especially if the patient has the idea of developing pregnancy after transplantation. We must explain this complication. CD counts we don't usually monitor. So IVIG, I don't use it. Only if they develop antibody mediated rejection, I do use it with the plasmapheresis. So target serum albumin is 3 to 3.5, serum fibrinogen and activated partial thromboplastin time to be monitored. Fibrinogen should be kept more than 200, and low level of fibrinogen has to be corrected by cryoprecipitate. Prolonged partial thromboplastin time should be corrected by FFP. So induction therapy, I usually give basilicimab. Maintenance, tacrolimus, mycophenolate mofetil and prednisolone. There is no need for increased immunosuppression for ABOi incompatible transplantation. So post-operative plasmapheresis, we don't, previous days we used to monitor these titers after the transplantation, but the Transplant Society of India, to reduce the cost, if the creatinine and graft function is normal, this monitoring is not necessary. So the routine monitoring is not necessary after the transplantation unless there is a gross graft dysfunction. So immunologic accommodation, as I said, how this varying blood group is accommodated in the body of the recipient. The presence of detectable agglutinin titers, AB endothelial antigen expression, and positive peritubular capillary staining without any histological evidence suggest ABOi immunological accommodation. If the same thing is present with histological damage, it will suggest antibody mediated rejection. That is, this reaction will happen, but it is accommodated without any injury to the kidney. That is what is our aim. That's what is normally happening in the pregnancy. So this is the telltale evidence of reaction does happen, but without any tissue damage. There is a uniform staining of the capillary endothelial cells without any tissue damage. So surgical complication, there will be as usual, perioperative bleeding will be there. If the INR is less than 3, we generally accept for surgery. If the INR is greater than 3, we have to give donor specific ABO type or fresh frozen plasma. Infection, yes, definitely, because we are middling with the immunological system of the patient. So higher risk of infection is generally expected: pneumonia, UTI, pyelonephritis, wound infection, polyoma, BK virus nephropathy. Usually we give valganciclovir for 900 milligram for 3 months, Septron for 1 year to reduce the risk of pneumocystis coronary infection. There is no risk of no increased risk of malignancy. So outcome compared with ABO compatible, ABOi has lower graft and patient survival within the first 3 years. However, the long-term survival, that's what I have shown in the earlier data with various centers, they report between 87 to 100% success rate. But overall, there is no difference in the risk of overall borderline or T-cell mediated rejection between the groups. However, ABO transplantation is associated with higher risk of antibody mediated rejection. So reducing the cost, low dose rituximab by using specific donor group FFP and less amount of albumin, reduce the number of plasmapheresis session, and all these things, they will avoid coagulation derangement, which may be beneficial in reducing the cost of the patient. So ABO incompatible transplantation is a promising option for increasing donor pool in living related kidney transplantation. The outcome in terms of short term and long term survival seems to be good by experience with our center and with various centers in India. Of course, Japan is very superb indeed. We cannot compare with that. Thank you.
Thank you so much for the very beautiful, clear and excellent presentation on this topic. And Venkat is one of the brilliant alumni of 1984 batch. அந்த காலத்துல ஒரு சிலரெல்லாம் நாங்க படிப்ஸ் அப்படின்னு சொல்லுவோம்ல, அந்த மாதிரி எப்பவுமே படிச்சுக்கிட்டே இருக்கிற வெங்கட் இங்க வர வைக்கிறதுக்கே பெரிய இதா இருந்துச்சு. இல்ல நான் வரல, என்ன வரல, அதெல்லாம் வந்துதான் ஆகணும் அப்படின்னு சொல்லி வர வச்சிட்டோம். அதனால thank you so much Venkat. Now I invite, we have to honor Venkat on the stage. Please be on the stage. And I invite Dr. Somasundaram, and one of the proud alumni of the 84 batch, and Dr. Mahalakshmi. Mahalakshmi is the professor of OG, Madurai Medical College, and Somasundaram is the additional director of the Public Health Chennai. Come on the stage to honor Venkat, please. photo. Now we move on to the next topic, which is understanding diabetes remission by Dr. M.R. Vidya, MBBS, DNB, MNAMS, Medical Director, Senior Consultant Physician, Diabetologist, MVR Medical Center, Puducherry. இப்போ வெங்கட்ராமனை சொன்ன மாதிரி அடுத்து வித்யா. எங்கள் ரூமுக்கு பக்கத்து ரூம் தான், ஆனால் நாங்களாம் ஊரே சுற்றுவோம். ஆனால் வித்யா ஆல்வேஸ் ஸ்டடிங் இன் த ரூம். வித்யாவை பார்த்து தான் நான்லாம் படித்தேன்னு சொல்லலாம். So, one more proud alumni of 84 batch, and she finished her DNB after MBBS from Apollo Hospitals, Chennai, from 93 to 96. He is the founder and medical director of MVR Medical Center, the first comprehensive diabetes care and multi-specialty center of Puducherry, and Vidya involved in so many public health activities and awareness programs in All India Radio and so many TV shows, and she conducted so many village camps to spread the awareness of the diabetes, and she is treating so many poor in and around Puducherry. Vidya is a very big known figure there. And coming to the academic side, as I sollave vendam, published many articles in JAPI and API textbook, authored many chapters along with Dr. Seshaya. Actually, Seshaya, she always says mentor to Vidya, and it is one of the proud and credit that one of the great person is our mentor and direct the association between Vidya and Dr. Seshaya, and diabetes education of the patients. That is very important. Over to Vidya about the topic, please.
Thank you. Thank you for the nice words, Tamil. Good morning, friends and students. After nearly 3.5 decades, I have come to Government Rajaji Hospital, so it's indeed a proud moment for me. So let us start our talk. So here first in the next few minutes we'll concentrate on what is remission. First we should understand about remission, then how to induce remission, and what do we call as remission. This is quite a new term for the students, I believe, and it is relatively a new topic among conferences also, even among specialists. And then who can achieve and who cannot achieve remission, and follow up and summary. So far what has been taught in the textbooks is the natural history of diabetes is one of progressive decline in beta cell function, and it is a disease which relently progresses and going towards complications, and there is no cure for that, and in fact no reversal was thought of about 2 to 3 decades back. So there are, anyone will exist in 3 stages: a normoglycemia or a pre-diabetes. Actually this concept of pre-diabetes itself is more created more awareness among the medical fraternity, one in the last 1 to 2 decades. And then clinical diabetes. Of course we all know the values criteria. Pre-diabetes I like to highlight 100 to 125 is isolated fasting impaired fasting glucose, and 140 to 199 whether it is a postprandial or a post-glucose sugar, it is pre-diabetes. So the chronic and the progressive nature of diabetes that demands long-term medical alteration and a constant assessment to reduce the risk of microvascular and macrovascular complications. So even with intensive interventions and follow-up, that can only effectively delay many complications and not totally prevent the complications. So therefore, we have to think about achieving remission of diabetes so that the complications can be prevented. Actually, the earliest documented evidence on remission was primarily of surgery. So there is bariatric surgery reports were the first one which gave the idea. So actually remission is defined as an A1C, HbA1c of less than 6.5% measured at least 3 months after the cessation of any glucose lowering pharmacotherapy as the diagnosis. And so in some places actually A1C is not standardized still in many parts of India and many other countries. So there we can consider a fasting plasma glucose of less than 126 also as remission. 2-hour glucose test is not now considered necessary, but our Indian studies include that also. Certain enthusiastic diabetologists are doing this. You would have heard about several diabetes reversal programs. They include GTT clearance as a criteria. But as per ADA consensus group, GTT clearance is not mandatory. So hyperglycemia is a continuum. So cure is not an appropriate term. That's why the 2021 consensus group, actually they included an oncologist, because even in cancer there is no cure, because anytime there may be a recurrence. So they never use reversal or cure, they use remission. So that same terminology was brought to diabetes remission also. This is for the students. The top one is, this is one of normoglycemia. Is it visible? Yeah. This is one of normal CGM, continuous glucose monitoring of a normal person. See here you get the estimated A1C. This is of a diabetic person. See, it is 7.6. So this can also give a precise status of an individual. What is the physiological basis of remission? So they found that in many studies, US has done most of the studies. So US women, they studied thousands of women and they found that BMI, the diabetes relative risk correlates with the BMI. So if you see a BMI of 22, it is 1, and just I am highlighting few BMI values to show the increasing risk of diabetes. So with 26 BMI it is 8%, and with the 29 to 30 it is 27%, and when it comes to a BMI of 35 gross obesity, it comes to 93% risk. So now we know that weight gain or obesity is the major factor in the pathogenesis of diabetes. We have got so many information about the etiopathogenesis of diabetes from the results which we got from remission. Whoever achieved remission, from them we got this hypothesis. So actually this was twin cycle hypothesis was brought about by Roy Taylor, who was the pioneer in the direct study, which we'll see in another few slides. So he gave this hypothesis that there are 2 cycles occurring in the body's metabolism. One is a liver cycle, other one is a pancreas cycle. So liver cycle here, everything starts with the positive calorie balance. That is, here positive energy balance is a more decent term. It is excess calorie intake, excess food intake, to put it bluntly. So when there is when we take more than what is needed, when we eat a heavy food, what happens? The body says we will store it for future. So it is converted as a fat and stored in the liver. So what it leads to increased triglyceride level, and it is shifted to other viscera. So there when it goes to pancreas, increased islet triglycerides, that leads to beta cell dedifferentiation. So there is cellular level dysfunction that leads to decreased insulin response to whatever glucose we take, that is carbohydrates we take, and so that leads to postprandial hyperglycemia. What it leads subsequently, the hyperglycemia is adjusted by our body's mechanism that leads to hyperinsulinemia, which is compensated. So the basal insulin levels itself keeps increasing. So that again leads to, so this is a vicious cycle. So from pancreas it comes here, and here again there is resistance, and that leads to increased liver fat, more and more of insulin secretion. So more lipogenesis, more liver fat, and that leads to insulin resistance, especially the suppression of glucose production. Insulin suppresses glucose production, isn't it? That is suppressed by this liver fat. So it has become a vicious cycle. So this is a simple demonstration. So the main thing is the calorie excess. One is a liver cycle, one is a pancreas cycle. So chronic calorie excess leads to accumulation of liver fat with the eventual spillover into the pancreas, and this cycles between liver and pancreas eventually cause the metabolic inhibition of insulin secretion after meals and onset of hyperglycemia. So now we know that fat is the foe. So here it shows 30% of fat. See, when it is cleared after weight loss, it is just 2%, it is near normal. So when there is a weight loss, you will be surprised, there won't be any talk about diabetes. Actually this is about a weight loss. So when there is a weight loss, there is disproportionate, which is beneficial to the metabolism and for diabetes. So 16% weight loss leads to 27% of total body fat, whereas it leads to 30% of intra-abdominal fat and about 65% of intrahepatic fat loss. This is very, very beneficial. So these are some of the metabolic effects. You can't read everything, I think. Actually it gives benefits in several metabolism, that is in glucose levels, insulin levels, triglycerides, liver enzymes, CRP. CRP of course only when there is a 15 kg weight loss. This is 5%, 10%, 15%, sorry, 15% weight loss. It improves the inflammatory markers also. Then it improves the insulin sensitivity in adipose tissue, liver and muscle. Even beta cell function improves. We can measure all this experimentally, okay, and by simple calculations we can do. And more importantly, they have found out that with weight loss there is upregulation of genes involved in the cholesterol flux and downregulation of genes involved in the lipid synthesis, and oxidative stress, everything gets downregulated. So to understand, remember grossly, a fatty liver, when you lose weight, it becomes a healthy liver, and even a reduction of 1 gram of the pancreatic fat is just enough to bring about remission. So this is the remarkable benefits you can attain with a weight loss. But actually you have to lose 10 kg, 15 kg to bring that 1 gram loss, that you have to remember. Then effects on blood glucose, A1C, that we saw. Even hypertension gets reverted. So how to induce remission? I told you bariatric surgery gave us the idea. Surgeons brought this idea that diabetes can be cured. Initially it was thought it can be cured. Then they brought it can be brought for remission. Metabolic surgery is the term used for those without morbid obesity. Bariatric is for mainly morbid obesity patients. If you do the same surgeries for people without gross obesity, it is metabolic surgery, they say. Then by dietary intervention, that we see in detail. Then intensive lifestyle intensification and drugs. So this is bariatric surgery. Here I won't go into the details, being a physician. These are the methods they do: sleeve gastrectomy, gastric bypass, gastric banding, and biliopancreatic diversion. So how it brings about remission? There are hormonal changes, increased GLP-1 levels, GIP levels, increased insulin release, that whatever insulin secretion that was suppressed, the first phase insulin secretion, that improves. Then also with gastrectomy and volume loss, all that, there is small absorption. Naturally a patient cannot take food, So decrease snacking. They also give psychotherapy, counseling, etc. before bariatrics. So behavioral changes also play a role, and modification of gut microbiota. That is another one big theory that is proposed. And also, this is another one recent study. It is a retrospective study published last year. So here it was found that even when the BMI is near 50, and when you can achieve with 5-year remission, you can long-term remission, more than 5 years, you can achieve in nearly 50% of patients. So this is a remarkable result. But this is a collective evidence from so many patients. It is a retrospective study of the medical records. So now we come to dietary intervention. Why we thought diet is important? Because in the bariatric surgery, they found the results. Also, pre-op for few weeks, they trained the patients with low-calorie diet. So they thought, why can't this be a very good, because post-operatively they will suffer, otherwise bariatric surgery patients. Suddenly if the calories are brought down, metabolism will go haywire. So that low-calorie diet, is it playing a role? They wanted to study. So they had a few studies. These two are like pilot studies, 10-15 patients. They gave a low-calorie diet and saw. Direct study is the one which I told, from this only they postulated the theory of twin cycle theory. Look ahead theory is another one. This too we'll see in little detail. Direct OS is the same study, low calorie diet tried in Australian patients population. Diadem, they studied same dietary formula they used in Middle East and North Africa. And standby they tried in South Asians of UK. Whoever is living in UK, they tried. We'll see the two studies in detail. So as I said, this is with a small number of patients and with a 8-week period. They gave a very low calorie diet, around 800 calories. And here if you see, within 1 week the results were shown, and the top one is the pancreatic triglyceride levels that keeps on decreasing and becomes normalized by 8th week. So here is the fasting first phase insulin response. So here it is almost nil, then gradually it is increasing and it is near normal at 8 weeks. So this gave encouragement for further studies. So this is the direct study with which is diabetes remission clinical trial. This in UK they did with the diabetes UK program. It was their program, and in 49 primary care centers of Scotland and England they did this. And here they found that a weight loss of 15 kg or more in 36 participants was a remarkable achievement, and no participants achieved that in the control group. And diabetes remission in 68 participants in the intervention group, that is almost 50%, they achieved remission. Here this is, I am simplifying this. So if the mean body weight reduction is about 10 kg here in the intervention group, A1C comes down by this arrow should be here, 0.9%, it comes down. Whereas in the control group there is marginal weight loss or weight gain, and there is a 0.1% increase in the A1C. So this is again the same. As how much weight you lose, that much percentage remission you can get. So the results are directly proportional to the weight loss. So they found that this is practically possible. Actually what diet they gave here, this is not permanently practicable. What they gave was a formula feed. It was 800 to 850 calorie liquid diet with a good balanced food, and after 8 weeks they gradually, this is called TDR, total diet replacement, then gradually they brought in the normal diet, and slowly they adjusted the medicines, and gradual tapering of medicines, and also exercise program very gradually they brought in. This should be done only under the supervision of trained physicians and not by anyone else, because we have heard so many weight loss programs with formula diet where they undergo so many complications, even risking their life. So at 2 years they found that this was the pancreas in the beginning with lot of fat. The morphology is altered. Gradually within a few weeks, few months, it reaches near normalcy, and at 2 years it is almost like a non-diabetic pancreas. So in 5 years also you can continue, even with the practitioner support it is 13%. Even if they are not continued in the study, if they are motivated and if they keep on losing weight, the remission continues. But you can see the percentage, it is just 5 to 10% at 5 years. This is another one study, look ahead trial. Here they studied large number of patients, thousands of patients, and for 12 years, here they concentrated on the complications. So they found that whoever achieved remission, they had a 33% lower rate of CKD. So whereas those who did not achieve remission, they went on for CKD progression. Just now you listened to our great nephrologist, how much kidney function is important and preventing them from going for the stage of transplant and all that. So it is a great thing. If you achieve remission and if you prevent a person going into CKD, that is a great thing for their life, isn't it? And then 40% lower rate of composite CVD endpoints. Then the same Diabetes UK group, they studied in non-obese individuals, that is BMI less than 27. So this study also showed they also have a benefit of a remission of diabetes, and that was proven by MRI, that there is loss of pancreatic and liver fat. And with this retune study, they got one idea, that is, even if there is not obesity, when there is a loss of fat, it is definitely helping. That is called a personal fat threshold. I will discuss this later. So this already I have told. This is one other study they have done in Maharashtra, but very few numbers, 12. So this is certain, I will just rush through the slides to have some idea how much is. So we saw around 15 kg, whoever is overweight, we should aim at reducing the weight at least 15 kg. 15 kg not in 1 year or something, over 4 to 5 years. In the youth itself, if the program starts, it is good. Only our mindset should be towards weight loss. And it should be at least for a period of 3 years, because nowadays we are seeing diabetes even in +2 students. And I have a patient who is a NEET aspirant who wrote for 2 years, sat at home and read, and he developed diabetes. And now he is under obesity clinic. He is under our follow-up. So maintaining the weight loss is another one big issue. First, motivating the person to lose weight, then maintaining that weight loss is next big thing. So what is the problem in our food? Why Indians are so prone for diabetes? Because our food is like that. We generally have an idea that fat is worse, and fat creates obesity, and fat gets deposited everywhere. It is not so. Whatever carbohydrate we take is directly converted to fat, and liver stores that nicely. So the carbohydrate portion should be reduced in Indian diets, whether it is east or west or north or south, chapati or rice. Carbohydrate portion is even 70 to 80% in our diet. It is shown by studies, field works, and it should be brought to 50%. General other balanced food is around 60%, but to prevent diabetes, if you bring it to 25% protein, it will be fine. Actually, this protein content, they have done another study based at Chennai. If you increase your dietary protein in each meal by 10%, just add some peas or some sprouts or some paneer, something like that, or egg, you are going to prevent diabetes, because that prevents the glucose spike after a high carb meal. So how to cut down the calories? On one side, you can reduce the diet daily, some 200 calories if you reduce. For example, if you eat 6 idlis, if you can reduce 2 idlis morning and 2 in the evening, 1 idli is around 50 calories. For 200 calories, you can come down. Like that, you have to calculate. So this interest youngsters should develop from their initial period of career, because you are going to face still more epidemic of diabetes and cardiovascular disease. So this education of patients is very important. And then 200 calories they can burn by physical activity. So lifestyle intervention, we haven't got much studies, big studies, but some studies show that it gives results. We all know, practically we know. Only thing is we don't have documentation and it is being done. One study from Bangalore, Vaidehi Institute, they have got, but that is again a very minimal patient, 30 patients. So lifestyle modification is very important. So one should have a healthy diet. It is good sleep is needed, which is lacking in medicos, whether they are students or whether they are consultants. Then reduce the stress levels by yoga, pranayama. One study from Chennai, Arumbakam, they have shown that in 4 patients they could achieve remission with the yoga and other lifestyle modification. Then exercise, of course, it is important. Reduce the screen time. This is very, very important for youngsters. Then use smartphone apps for step counting. Drugs and remission, this I'll go briefly. Short-term intensive insulin therapy at the diagnosis of diabetes. This was highlighted as a main therapy about 7-8 years before. This was I can say this was given lot of importance, but now we have very many good drugs. So this has taken the back seat. So here this is progression to diabetes, this is reversal. So that is the guideline to show. So here some of the drugs you see. SGLT2 inhibitors, they are the molecules of the decade. They their mechanism is different. They create urinary loss of glucose, which can bring down to up to 30% loss of calories. So they help in weight loss. That was discovered only while patients were studied. So it was not the aim of researchers to bring down the weight loss, but it occurs. GLP-1 receptor agonists you would have read. So that is liraglutide and all that. They bring about very good weight loss. Then metformin itself brings weight loss. Of course, bariatric surgery brings weight loss. So this are so here you can see a word, personal fat threshold. This is what I told. This theory is understood now only. That is, one person can be very fat, but he may not have any diabetes, any disease at all. But whereas another person may be lean and little put on some 5 kg, 6 kg weight and he may develop diabetes. That is because he is crossing his personal fat threshold. This theory is quite new. So this was GLP-1 analogs. It improves everything. Beta cell function is improved, beta cell glucose sensitivity is improved, then all this are improved, parameters are improved. First phase insulin is improved, and beta cell apoptosis is decreased, and there is also theoretically increased beta cell mass. This we have to find out in humans how far it is there. So there are other drugs also. Orlistat, we use only this in India. It has a modest effect and it has no side effects, so that much it is useful. Other glucose lowering drugs also help in weight loss, metformin, AGI, GLP-1, SGLT, and other combinations of these drugs. This tirzepatide is another new drug. Very soon it will be coming to the market. And so they say the weight loss effect is equal to bariatric surgery. It is a dual agonist with GLP-1 agonist and GAP agonist. This I think NEET aspirants will be knowing. They will get questions on this. So these are some of the drugs. Rosiglitazone was one of my favorite drugs. So 10-20 years before when we prescribed, this was banned actually. They told it has cardiac side effects and all that. But even with 1 milligram, you could achieve remission and patient won't come back for 5 years, 6 years. Later they will come, madam, you gave one tablet, my diabetes got cured, and I became so popular in my area that this doctor is curing diabetes. But I was unaware. But after several years they came back. I never came because my sugars were normal. Now only I am finding it on the higher side. So I am coming back to you like that, they say. So then SGLT2 inhibitors, this I told already, they have another very, very fantastic benefits on cardiac disease and CKD. So these drugs are darlings of cardiologists and nephrologists too. This line I wanted to tell about type 1 diabetes. Actually, type 1 diabetes, we should not say they can try for remission. Never we should give a promise because that is risking their life. If they listen to such a thing and if they stop insulin, that is dangerous. So, but they are trying immunotherapy, islet cell replacement, transplantation, everything. We can expect in another 1 or 2 decades results for that also. So, who we can plan for remission? Who we can say they are suitable candidates? We can't say everyone. When they are coming irregularly, even for diabetes management with very uncontrolled blood sugars and no idea about diet, you can't say you come for vigorous dieting and you have remission. So patients should be highly motivated, and diabetes duration within 6 years will give a good result. And if they are not on insulin, it is preferable, because suddenly if you withdraw, they can go for decay. That is the thing. So these are certain words of caution. Then those who are without complications, well and good, they can be tried. So you have to do screening before starting this intervention. Who cannot be considered for remission? I told you type 1 diabetes cannot be considered, FCPD, other genetic syndromes. Then who can't be suitable for exercise programs? CHF patients, they should not be tried. And those with eating disorders, of course you can't try, that is very obvious. Those with diabetic complications. If the patient has a significant retinopathy or nephropathy or neuropathy, if you try suddenly, if you try to withdraw the drugs and change the diet, and if intensely bring down the blood sugar at very low levels, retinopathy may worsen, neuropathy may worsen. So you have to be very careful in considering these patients. Then predictors, who all we can predict? There are a predictor criteria for bariatric surgery also, and this is generally for anyone. So if they have to start with, if at the baseline, if they have a lower A1C level, if they are young, if they have fewer medication, not on insulin, greater degree of weight loss if they achieve, they are going to succeed in getting remission, and shorter duration of diabetes. So once remission occurs, can you send the patient that go bye bye, you are not no more my patient? No, you can't say like that. You have to keep regular follow up. You have to educate them. So I am very interested in education. So I spend lot of time with a single patient. So I will say, you have to come back at this time. Every 6 months you have to check. Every 1 year you have to check. Like that, you have to spend time with the patients. Nowadays I am seeing some doctors don't even say patient name. They will say case. Like that. You have to develop a personal rapport, and patients should believe you, your words, then they will follow correctly. And this thing is another one important thing, that is legacy effect. This legacy effect was first told in DCCT trials, that is in type 1 diabetes and the UKPDS trial, type 2 diabetes. They controlled intensely for several years. After stopping all the intensive treatment, after 10 years also, they had the benefits of that strict diabetic control. So the complication rates were very less. Here, like that, you achieve remission, but patient would have had hyperglycemia several years before. That effect may be there. So you should not forget to screen for yearly screening of diabetic complications. Then this I told you, and lifestyle should be maintained. So recurrence, of course, even after bariatric surgery, they develop weight gain, and they gradually go to their lifestyle. They did follow means they will put on weight and they will go back to the diabetic state. So stress is also a factor. Progressive decline of beta cell function may occur, and diabetogenic drugs, as Dr. Venkat was telling, steroids if they are used and all that, you will have them. So here from now we know that diabetes is no more glucose-centric approach. We are going to change it to weight management in another few decades, and guidelines are going to change soon, and increasing the drug dosage we are doing now, that should be converted to gradual tapering and attempt for remission. Lifelong diet and lifestyle changes are needed, and the education of the patients on weight loss to achieve remission is the need of the hour. So you have to start early, and success is yours. And more than anything, remission is not a destination, it is a continuous journey. So thank you.
Thank you, Vidya, for the very useful presentation. Diabetes can be have a remission actually, and weight reduction plays a major role, and lifestyle modification have a major role. It is an eye opener, and it is useful to everyone I was thinking to see this YouTube streaming again by all my classmates and all the people who are in our age actually. Okay, thank you so much, Vidya. Now I invite Dr. Kumaraguru onto the stage to honor Vidya, and Dr. Uma Mohanraj onto the stage to honor Vidya. Dr. Uma is HOD, Professor of OG, KPV Government Medical College, Trichy, and Kumaraguru is a very, very, very dedicated anesthetist from Srivilliputtur. Now the third topic is slight change in the program. The third topic is by Dr. K. Sivakumar, Professor and HOD General Medicine, Coimbatore Medical College. The topic is resistant hypertension.
Professor Dr. Sivakumar is another proud 84 in alumni. He joined government service in 1991 and he did post-graduation general medicine from Stanley Medical College in 95 to 98. He joined in Coimbatore Medical College in 1999. He has completed 25 years of service in medical college only. And he was promoted to professor in Dharmaburi Medical College and became HOD in 2012. And he is very experienced and he has been HOD medicine since several years in Coimbatore Medical College. He has taught and several postgraduate and undergraduate students in general medicine. Now he is going to talk about resistant hypertension, which is a very important topic. And now over to Dr. Sivakumar.
Good morning, classmates and students. 25 years in medical college is a blessing, I believe. So I worked in various, starting from casualty and nephrology and medicine department, and I had a very reasonably good experience in epidemics. Almost I have seen 3 epidemics of COVID, and I was one of the medical officer in charge of COVID casualty outside the hospital. So these are all part of the government, but I am an above average student. And the padipps mari ellam kedaiyadhu. So adanaala everyone, my principle is everyone will have a cake to eat, but the pastry or a cake decided by you, not by the. So made good effort, you can take a pastry. Average effort, you will have a tea cake. That's all. But everyone will have a cake to eat. Okay. With this brief introduction, my topic, resistant hypertension. Next. So resistant hypertension is defined as a blood pressure that remains above goal in spite of concurrent use of 3 antihypertensive agents of different classes. One of the 3 is a diuretic, and all agents should be prescribed at optimal dose in amount. So if you go through each word, the resistant hypertension per se is very minimal for a general practitioner, for a general physician. It is only a specialist, the top of the layer, the cream of the layer, like nephrologist or a cardiologist, whatever it is. Not for the general physician or a general practitioner. Okay, so minimum of 3 drugs irukano. Oru drug diuretics. Okay, right. Coming to the resistant hypertension includes patient whose blood pressure is controlled with the use of more than 3 medications, that is patient whose blood pressure is controlled but require 4 or more medications. So இது இன்னொரு different way of approach. So 3 medication 1 diuretic லையும் கிடைக்கல அப்படின்னா we will add up 4th drug. அந்த மாதிரி இருந்ததுன்னா resistant hypertension சொல்லுவோம். Next. So is there, நம்ம எடுத்தோடனே physicians are always fond of differential diagnosis. So இதுவா அதுவா மாடு மாதிரி இருக்கா மாடு அப்படின்னு சொல்லுவோம், மாடு மாதிரி இருக்குன்னு தான் சொல்லுவோம். So that's why we call it as a true resistant hypertension and the pseudo resistant hypertension. So patients with the true resistant hypertension are those who have uncontrolled clinical, that is office, Americans are interested in office BP measurement, we are interested in clinic BP measurement, despite being adherent to an antihypertensive regimen that includes 3 or more drugs including a diuretic with optimal dosage, and the blood pressure elevation is confirmed by your 24-hour ambulatory blood pressure monitoring, or if the 24 hours monitoring is not possible, a homemade BP apparatus. So நம்ம எல்லா ஊர்லேயும் நம்ம யூஎஸ்லேருந்து யூகேலேருந்து BP பாக்ஸ் வாங்கி கொடுப்பாங்க, காம்ப்ளிமெண்ட்டாக கொடுப்பாங்க. So that record also can be taken up. And the pseudo resistance next is when there is a true, but there is always a false also there. So pseudo resistant hypertension refers to poorly controlled hypertension that appears resistant to treatment but actually attributable to other factors. So maybe most of the time patient related, environment related, medicine related, then comorbidities, so many factors. Okay, so this is about the two differing presentations of resistant hypertension. Next, so factors attributable to pseudo resistant hypertension: inaccurate BP measurement, especially inappropriate. Yes, everyone knows we have a standard size for every single size shoe fits for every BP measurement. See, even in corporate hospital also the same picture, so don't worry about it. அதனால வந்து, and I yet to find a thigh cuff BP cuff from a surgical store all over the country. அதனால் அது கிடைக்கவே மாட்டேங்குது. We always say 2/3 of the arm should be, 2/3 of the measuring limb should be covered. அந்த மாதிரி கவர் ஆகிற மாதிரி உலகத்தில் இன்னும் கஃப் வரவே இல்லை. ஒன்லி பீடியாட்ரிக் அண்ட் நியோனட்டல் கஃப் இஸ். அது இப்போ புதுசாக நம்ம அந்த மெஷின்ஸ் வர ஆரம்பித்தோம்னா தட் சேவ் சம் சார்ட் ஆஃப் இது. பட் எவ்ரி ஒன் கேனாட் அஃபோர்ட் தட். இது ஆல்மோஸ்ட் 1.5 lakhs ஆகுதுன்னு நினைக்கிறேன், ஐ பிலீவ். ஓகே, ஸோ தட் கஃப் ஷுட் பி inappropriate இருக்கணும். பட் unfortunately inappropriate small cup will have a erroneous recording of. Then poor adherence of antihypertension, that is the most important patient factor. It cannot be measured. ஏன்னா பேஷண்ட் சொல்லுவான், நான் சாப்பிட்டேன் சார், சத்தியமாக தான் சாப்பிட்டேன் அப்படிம்பா, பில்லு இருந்து கொண்டு வந்து காமிப்பா, சாப்பிட்டானா இல்லையாங்கிறது தெரியும். ஸோ புவர் அட்ஹரன்ஸ், ஸோ யூ ஷுட் ஹாவ் அ கான்ஃபிடன்ஸ். தென் சப் ஆப்டிமல், தட் இஸ் டாக்டர் ரிலேட்டட். சி வி மே நாட் ப்ரிஸ்கிரைப் an optimum dose recommended by the guidelines. Then another thing, நான் மாத்திரையெல்லாம் சாப்பிட்ருக்கேன், ஆனால் சரக்கும் சிகரெட்டும் குடிச்சிட்டே தான் இருப்பேன் அப்படி. ஸோ புவர் லைஃப் ஸ்டைல் மேனிஃபெஸ்டேஷன், புவர் அட்ஹரன்ஸ் டு லைஃப் ஸ்டைல், ஸ்ட்ரெஸ்ஃபுல் லைஃப் ஸ்டைல். அடுத்தது வந்து டயட்டரி அப்ரோச்சஸ். நல்ல சால்ட்டு கருவாடியும் ஊறுகாயும் சாப்பிட்டோம்னா எங்கே போய் பிபி கண்ட்ரோல் ஆகிறது? ஆகவே ஆகாது. சரியா? புவர் அட்ஹரன்ஸ் டு, சாரி நான் தமிழில் பேசுகிறேன்னு கோச்சிக்காதீங்க, அது அப்படியே பழகி போச்சு. பிகாஸ் வி சி பீப்புள் ஹூ ஸ்பீக் த ஸ்டேட் லாங்குவேஜ். சரிங்களா? இந்த புவர் அட்ஹரன்ஸ் டு லைஃப் ஸ்டைல் அண்ட் டயட்டரி அப்ரோச்சஸ் டு லோவர் த பிளட் ப்ரெஷர். தே ஆர் நாட் லிசனிங் டு த டயட்டரி ரெக்கமெண்டேஷன். தென் ஒயிட் கோட் ஹைப்பர்டென்ஷன். எனக்கு ஆஸ்பத்திரி வந்தாவே டென்ஷன் சார், உங்களை பார்த்தாவே டென்ஷன்மா, அது ஒரு குரூப்பு, ஒயிட் கோட் ஹைப்பர் டென்ஷன். இப்போ எங்களுக்கு சோம்ஸை பார்த்தா எப்போவுமே டென்ஷனாக தான் இருக்கும். எனக்கு இஸ் அவர் டைரக்டர், சரியா? இஸ் மை என்ன சொல்கிறது, பார்ட்னர் சின்ஸ் ஃபஸ்ட்டு பிபி அனாட்டமிலேருந்தே என் பக்கத்துலேயே இருப்பான், திட்டிகிட்டே இருப்பான், படுறா அப்படிம்பா. தி ஒயிட் கோட் எஃபெக்ட் இஸ் டிஃபைன்ட் அஸ் அ ஆஃபீஸ் பிபி எபோவ் கோல் but out of office BP levels measured by ambulatory BP monitoring or home BP monitoring. Below goal in a patient on more than 3 antihypertensives. It is true for every, especially when you prepare for an elective surgery. or when you prepare examining a patient in an obstetric இது ஸோ ஆல்வேஸ் the white coat because stressful factor மாமியார் வந்துருங்க பக்கத்தில் ஆன்டிநேட்டலோட என்ன சொல்லுது டெலிவரி நார்மலா இல்லையா அது ஒரு போட்டு ஒரு டார்ச்சர் ஒரு 128க்கு பதிலாக ஒரு 138 இருக்கும் சுகர் வேல்யூ உடனேன்ட்டு ஸோ தட் கிரியேட்ஸ் இது ஸோ அது ஒன்று ரெண்டாவது ஹோம் என்விரான்மெண்ட் ஆல்வேஸ் வி ஆர் கம்ஃபர்டபுள் அட் ஹோம் சரியா ஸோ அதனால் அந்த இது மேபி ஒன் ஆஃப் த ரீசன் தென் த ரிஸ்க் ஆஃப் cardiovascular system disease complications in white coat effect is similar to that of in hypertension. So the morbidity and mortality of other the vascular events is similar in a white coat hypertensives also. That's why we are targeting these people also. Okay. Then coming to the definition, some degree of BP rise is seen in office measurement in the majority of the people. However, the white coat effect can be magnified in individuals with diagnosed with hypertension in women, other older individuals. Okay, older individuals always have some other problems also. ஒரு இடத்துல இருக்கணும், அப்புறம் சாப்பிடணும், அப்புறம் பாத்ரூம் போகணும், அந்த மாதிரி ஏதாவது ஒரு ஸ்ட்ரெஸ்ஃபுல் ஃபேக்டர்ஸ் இருந்துக்கிட்டே இருக்கும். அண்ட் புது என்விரான்மெண்ட், பொம்பளை பிள்ளைகளுக்கு குழந்தை வந்துருங்க, அவன் அப்போ தான் அழுவான், அப்போ தான் தூக்கிட்டு போகணும்னு நிற்பான், அம்மாவுக்கு சி திஸ் ஆர் ஆல் த இன்ஃப்ளூயன்ஸ். அது ஸ்ட்ரெஸ் ஜாஸ்தியாச்சுன்னா நேச்சுரலி த ஹார்ட் ரேட் த பிபி வில் ஷூட் அப். A clinically significant white coat effect may be present in 28 to 39% of individuals with pseudo resistant by office BP measurement. Okay, so this is almost பார்த்தோம்னா நமக்கு வர பேஷண்ட்டில் 1/3 of the patient அந்த மாதிரி தான் இருக்கும். Short duration of hypertension and the absence of diabetes mellitus or chronic kidney disease are all associated to pseudo resistant from a white coat effect. The white coat effect can be easily identified by 24 hours ambulatory blood monitoring. But இது வந்து ஒரு ஹாஸ்பிட்டல் பேஸ்டு என்விரான்மெண்ட்டில் தான் நம்ம பார்க்க முடியும். ஆஃபீஸ் ப்ராக்டிஸ் தட் இஸ் அவுட் பேஷண்ட் பார்க்குற செட்டப்பில் இருக்காது. ஸோ யூ கேன் ஆஸ்க் த பேஷண்ட் டு ரெக்கார்ட் த பிளட் ப்ரெஷர் வேரியிங் இன்டர்வல் அவர்லி பேசிஸ் சொல்ல செகண்ட் அவர்லி 8th அவர்லி அந்த மாதிரி செய்யலாம். பிகாஸ் மோஸ்ட் ஆஃப் த பீப்புள் ஹாவ் அ பிளட் ப்ரெஷர் மெஷரிங் எக்யூப்மெண்ட்ஸ் இன் தேர் ஹோம். Then coming to the real story, that is factors attributable to resistant hypertension எடுத்துட்டோம்னா lifestyle factors, everything anything. அதாவது நம்ம டான் டு டஸ்க்கு ஒர்க்கெல்லாம் இப்போ வந்து கிடையாது. அந்த காலத்தில் நம்ம தாத்தா காலையில் எந்திரிப்பார், சாயங்காலம் 7 மணிக்கு சாப்பிட்டு படுத்து தூங்கிடுவார். பிளஸ்டு பீப்புள். அந்த பிளஸ்ஸிங் நமக்கு கிடையாது. 1 மணி ஆனாலும் வாட்ஸ்அப்பில் மெசேஜ் போட்டுட்டு தான் படுத்து தூங்குவோம். ஒன்று. ரெண்டாவது ஒபிசிட்டி, தி செடன்ட்ரியில். இப்போ உதாரணமாக எல்லா இதுலையும் சொல்லுவோம். இப்போ என்னுடைய கிளாஸ்மேட்ஸ் யாருமே வந்து ஒபீஸாக நான் பார்த்துல, ஸ்கூல் கிளாஸ்மேட்ஸு. ஆனால் இப்போ பார்த்தோம்னா எவ்ரி கிளாஸ்மேட்ஸ், அதாவது நான் சொல்ல ஸ்கூல் கிளாஸ்மேட்ஸ் அந்த ஏஜ்லேயே ஒபிசிட்டி வந்து ஜாஸ்தி ஆகிடுச்சு. ஸோ தட் இஸ் ஒன். தென் கம்மிங் டு த ஆல்கஹால். இப்போ ஆல்கஹால்னு சொல்லக்கூடாது, மதுப்பிரியர்கள், சரிங்களா. தென் ஃபிசிக்கல் இன்ஆக்டிவிட்டி. ஃபிசிக்கல் இன்ஆக்டிவிட்டி, இப்போ நான் வந்து ஸ்கூலுக்கு நடந்து தான் போனேன். 1 கிலோமீட்டர் காலையில் எந்திரிச்சு 7 மணிக்கு நடந்து போயிட்டு டிஃபன் சாப்பிட்டு நடந்து போயிட்டு மதியம் சாப்பாட்டுக்கு நடந்து வந்து திருப்பியும் ஸ்கூலுக்கு போவேன். ஸோ ஆல்மோஸ்ட் தெரிஞ்சோ தெரியாமலே ஒரு நாளில் வந்து 4 கிலோமீட்டர் நடந்தே ஆகணும். இப்போ வந்து அந்த ஃபிசிக்கல் ஆக்டிவிட்டி கிடையாது. இப்போ நம்ம வந்து ஜிம்முக்கு போய்த்தான் நம்ம ஃபிசிக்கல் ஆக்டிவிட்டியை வந்து, அண்ட் ஆல்சோ வி ஆர் ட்ராவலிங் 30 கிலோமீட்டர்ஸ் ஸ்கூலுக்கே போகிறோம். அந்த மாதிரி அது தட் இஸ் ஃபிசிக்கல் இன்ஆக்டிவிட்டி. தென் டயட்டரி பேட்டர்ன். You think you get it and you can eat it. That's the slogan nowadays. I believe everyone accepts it. Okay. Then drug related. Not only the drugs. See other diseases like OA, NEO, அல்லது வந்து ஒரு analgesics, வேறு ஏதாவது ஒரு drugs that complements that interacts with the blood pressure medicines or it reduces the efficacy. Then third thing is obesity ன்னு வந்துட்டாவே sleep apnea. Okay. So அடுத்தது வந்து secondary. That is a real cause for the resistant hypertension. Secondary hypertension organ related hypertension. So this is the reason how the obesity causes resistant hypertension எடுத்துட்டோம் அப்படின்னம்னா. So obstructive sleep apnea. Then obesity itself is an inflammatory state. Once there is an inflammatory oxidative stress, then sympathetic nervous system activation. When in the obese patient they have more sodium and volume retention. When there is more sodium and volume, then naturally the blood pressure goes up. Then all obese, when there is an inflammation, there is always an endothelial dysfunction. When there is an endothelial dysfunction, there is always a target, the vascular events. Then when there is an obesity, it's a role of diabetologist, remission, relapse, adala vandurum. Then when there is an obesity, that results in a renal dysfunction. When there is an obesity, you have more joint involvement, then analgesics, corticosteroids and all other things. So it is a vicious cycle. One trigger, multiple end organ damages. Okay. So this is, அடுத்தது வந்து obstructive sleep apnea. இது வந்து ஒரு complement to the obesity. Okay, obstructive sleep apnea is strongly associated with hypertension, and now அது ஒரு typo error, sorry, it predisposes to the development of hypertension. Sleep apnea is particularly common in patients with resistant hypertension. So நம்ம இதில் வந்து any resistant hypertension, first வந்து hypertension not under control needs various drugs அப்படின்னம்னா sleep apnea கண்டுபிடிக்கணும். But sleep apnea it's very difficult clinically கண்டுபிடிக்கிறது. பட் ஒரே ஒரு சிம்பிளான விஷயம், ஸ்பவுஸுக்கிட்ட உங்கள் வீட்டுக்காரர் வந்து தூங்குறப்போ கொரட்டை வர்றாரா அப்படின்னு மட்டும் கேளுங்க. சார் அவர் தூங்குறதுக்கு முன்னாடி நான் தூங்கிட்டேன்னா நான் நிம்மதியாக தூங்குவேன் சார்னு ஒரு ஹிஸ்ட்ரி வந்தது அப்படின்னா தட் மீன்ஸ் தட் ஃபெலோ இஸ் ஸ்னோரிங் அண்ட் ஸ்லீப் ஆப்னியா இருக்குன்னு அர்த்தம். ஓகே, திஸ் இஸ் அ சிம்பிள் திங். பிகாஸ் நம்ம ஸ்லீப் பேட்டர்னு லேபு அது இதெல்லாம் போய் பார்க்கறதுக்கு அனுப்புறதுக்கு முன்னாடி வீட்டுக்காரர்கிட்ட கேட்டிருக்கேன், அவன் தூங்குறதுக்கு முன்னாடி நான் தூங்கிட்டேன்னா நிம்மதிங்க, இல்லைன்னா முடிஞ்சதுங்க. That means OSA you have to rule out. Okay, then OSA is observed in, I believe, or OSA pati we have a CME. Unfortunately, I am not able to attend. So OSA observed in 30 to 40% of patients with hypertension and 60 to 70% of patients with resistance. So எல்லாருக்குமே இருக்கு, இது வந்து யூனிவர்சல் கிடையாது. OSA எப்படி குறைக்கணும்னா என்ன மாதிரி கழுத்தெல்லாம் வச்சிருக்க கூடாது, நீளமான கழுத்து இருக்கணும். Then diet. யூஸ்வலாக டயட்டில் வந்து சோடியம், நம்ம இதில் வந்து உண்மையாக நம்ம ஊரில் எஸ்பெஷலி மதுரை மக்கள் ஆர் ஃபாண்ட் ஆஃப் ஆடிங் சால்ட் டு தயர் ஃபுட். அதாவது ரைஸ் சாப்பிட்றப்போ சாப்பாட்டில் உப்பு போடுவாங்க, எங்கள் ஊர் பக்கம் வந்து சாப்பாட்டில் உப்பு போட மாட்டாங்க, சரிங்களா? ஸோ தட் இஸ் டயட்டரி இது. அதுக்கப்புறம் வந்து வாஸ்குலார் டிஸ்ஃபங்க்ஷன், தென் சிம்பத்தட்டிக் ஆக்டிவேஷன். நம்ம எப்போவுமே பண்டில் ஆஃப் நர்வ்ஸாகவே இருந்து பழகிட்டோம், ஒரு லைடு பேக் பாலிசி. சரி, இன்றைக்கி காலையில் அது டிப்பிக்கல் எக்ஸாம்பிள் எங்கள் சோமசுந்தரம் தான். மெடிசின் போஸ்டிங் கில்லிங் போட்டு காலையில் 6:55 வந்து எந்திரிச்சிருவோம், வந்துட்டா எந்திரா அப்படிம்பா. அப்போ நான் நான் ஓபிக்கு 8 மணிக்கு வரேன், நீ போயிரு அப்படிம்போம். அந்த லைடு பேக் பாலிசி ஆஃப் லைஃப் நாட் தேர். எவ்ரி ஒன், எஸ்பெஷலி மெடிக்கல் இப்போ இருக்கிற யூஜி ஸ்டூடெண்ட் எல்லாம் எடுத்துக்கிட்டோம்னா ஆல்மோஸ்ட் ஒரு நேர்ந்து விட்ட மாதிரி தான். அவனை வந்து காலையில் அதாவது லாட் ஆஃப் உட்டோப்பியன் தெரியும், அவனுக்கு வந்து உடல் பொருள் ஆவி இன்பம் எல்லாத்தையும் தாண்டி தான் அவன் படிக்கணும். ஒரு சிரிப்போடு அவன் படித்ததே கிடையாது, உண்மைதான். பிகாஸ் எவ்ரி ஒன் நோஸ் இட், பிகாஸ் இந்த 25. ஸோ அப்படி கிடையாது. திஸ் இஸ் ஒன் ஆஃப் த ப்ளஷரபிள் எஜுகேஷன் ஆல் ஓவர் த வேர்ல்டு. அன்ஃபார்ச்சுனேட்லி இவனுக்குனால அதை தாங்க முடியல, நம்மளை டார்ச்சர் பண்ணுறானுங்க, அவ்வளோதான், வேற ஒன்றும் கிடையாது. ஓகே, என்ஜாய் த மெடிசின், ஒன்றுமே கிடையாது. எவ்ரி ஒன் வில் ஹாவ் அ தேர் ஓன் டே. ஓகே, தென் கம்மிங் டு த அது இந்த டயட்டில் சால்ட்டு இதெல்லாம் காமிச்சோம்னா நமக்கு இருக்க காம்பன்சேஷன் ரெண்டு காம்பன்சேஷன் தான். ஒரு காம்பன்சேஷன் ஹைபாக்சியா ஆர் எரித்ரோபாய்டின் ஆர்பிசி ப்ராடக்ஷன். அனதர் காம்பன்சேஷன் ரெனின், ஆஞ்சியோடென்சின், ஆல்டோஸ்டீரான், சிம்பத்தட்டிக் சிஸ்டம், ஃப்ளூயிட் அண்ட் சால்ட் ரிட்டன்ஷன். முடிஞ்சு போச்சு. இந்த 2 காம்பன்சேஷன் தவிர்த்து வேறு எதுவுமே கிடையாது, ரைட்டுங்களா? அதில் ரெனின் ஆஞ்சியோடென்சின் ஆக்சிஸில் சப்ரஷன் ஆச்சு அப்படின்னா naturally hypertension will be the outcome. Then coming to the alcohol intake, heavy alcohol intake more than 30 to 50 grams. இது ஆல்கஹால் மாதிரியே இந்த கன்சப்ஷன் ஆஃப் ஆல்கஹால் இட் செல்ஃப் இஸ் அ கன்ஃபியூஷன். நம்ம குடிக்கிற ஆல்கஹால் வந்து 40%, 50% வால்யூம் பை பி அப்சல்யூட் ஏபிவின்னு போடுவான். படிக்கிறதுல எல்லாமே வந்து கிராம் கணக்கில் குடிக்கணும்பா. இருக்கிற ஆல்கஹால் பிரிஸ்கிரிப்ஷன் பார்த்தோம்னா எந்த ஆல்கஹால் எத்தனை கிராம் இருக்குன்னு யாருக்கும் தெரியாது. So it's very difficult. So அதனால வந்து that is no alcohol is the simplest answer, ரைட்டா? அதை விட்டு போட்டு நான் வந்து மாடரேட்னா ஹவு மச் மாடரேட் ஐ டோன்ட் நோ. நான் வந்து 4 பெக்கு போட்டேன்னா எனக்கு மாடரேட்டும்பா, ஒருத்தர் ஒன்றுலேயே மட்டையாயிடுவான். ஸோ மாடரேஷன் இஸ் நாட் இது. ஸோ இது எல்லாமே ட்ரேட் ரிலேட்டட். இது எல்லாமே பிஸ்னஸ் ரிலேட்டட். ஒருத்தர் ரெட் வைன் இஸ் ஹேவிங் ரிசார்சினால் அண்ட் ஆல் அதர் திங்ஸ்மா, அடுத்து உடனே அமெரிக்காக்காரனுக்கு வந்து என்ன ஆகிடும், ஒயிட் வைன் மட்டும் ஏன் இல்லைம்மா. ஸோ a simple no solves all your alcohol related problems rather than moderation இவ்வளவா அவ்வளவாங்கிறதெல்லாம் தெரியாது. ஓகே ரைட், that's a simple message I would like to give. The other risk factors, psychosocial stress, occupation, அதாவது சீஃப் அசிஸ்டன்ட் சண்டை, அதுக்கப்புறம் வந்து ஹவுஸ் சர்ஜன் பிஜி சண்டை, அந்த என் பையன் வந்து யாரு கூடயுமே பேச மாட்டாங்கிற சண்டை, அதுக்கப்புறம் லோ சோசியல். see when there is a problem, the support, there is no support system. அதாவது ஒருத்தருக்கு பிரச்சனை இருக்குன்னா அவனை சப்போர்ட் பண்ணுற கான்செப்ட் வந்து கம்மியாகி போச்சு, அவனை நம்ம வந்து டீமீன் பண்ணுறது இதுதான் ஜாஸ்தி. ஸோ அடுத்தது ஆன்சைட்டி, ஐயோ நம்ம எதாவது தப்பு செஞ்சிருவோமா, அந்த ஆன்சைட்டி, ஆங்கர், டிப்ரெஷன் அண்ட் ரெடியூஸ்டு. இன்னும் 1 மணி வரைக்கும் வாட்ஸ்அப்பில் உட்காந்துருந்தோம்னா எங்கே போய் தூங்குறது. ஸோ ஸ்லீப் டிப்ரிவியேஷன் அண்ட் குவாலிட்டி ஆஃப் ஸ்லீப், தட் இஸ் மோர் இம்பார்ட்டன்ட். அப்போ இப்போ வந்து என்ன நம்ம படுக்கணும்னு தூங்கணும், முதல்லலாம் வந்து எங்கே வேணாலும் படுத்து தூங்கிட்டு இருந்தோம். இப்போ வந்து முடிய மாட்டேங்குது. அது இல்லை ஃபர்ஸ்ட் என்னை இன்னமும் சொல்ல வேண்டிய எங்கடா எங்கே வேணாலும் படுத்து தூங்குறியடா அப்படிப்பானுங்க. ரைட், அவ்வளோதான். ஸோ அந்த குவாலிட்டி ஆஃப் ஸ்லீப், தூங்குவான் ஆனால் எப்போவுமே இது என்ன சோத்துக்கோழி மாதிரி கொயின்னு முழிச்சிக்கிட்டே இருப்பான். ஸோ அந்த இது இருக்கக்கூடாது. தென் ட்ரக்ஸ் ரிலேட்டட் இது, நான் ஸ்டீராய்டல் ஆன்டி இன்ஃப்ளமேட்டரி ட்ரக்ஸ், ஓரல் கான்ட்ராசெப்டிவ், சிம்பத்தோமிபிட்டிக்ஸ், சைக்ளோஸ்போரின், இவர் நம்மால் கோச்சிக்கூடாது வெங்கட்ராமன், டேக்ரோலிமஸ், எரித்ரோபாய்ட், இதெல்லாம் அவங்க தான் யூஸ் பண்ணிகிட்டே இருப்பாங்க. அப்புறம் கோக்கைன், ஆம்பிட்டமின்ஸ், ஆன்டி டிப்ரெசன், குளுக்கோகார்டிகாய்ட்ஸ், மினரலோகார்டிகாய்ட்ஸ், ஆல் தீஸ் திங்ஸ் ஆர் சம் ஆஃப் த ட்ரக்ஸ். ஸோ ட்ரக் ஹிஸ்ட்ரி யூ ஹேவ் டு எலிசிட். ஏன்னா சிலதெல்லாம் வந்து என்னென்னா பேஷண்ட் இப்போ வந்து ரொம்ப கிளவராக இருக்கார், அவரே வந்து நம்ம ஓபி டிக்கெட்டில் ஓபி டோக்கன், உனக்கு என்னையா கஷ்டம், கால் வலி, எலும்பு டாக்டர் போய் பாரு நம்பர் போடுற மாதிரி, அவர் வந்து எலும்பு டாக்டர் வியாதியை வந்து ஃபிசிஷியன்ட்ட சொல்ல, சார் அது உங்களுக்கு தேவையில்லை சார் அப்படிமா. ஸோ அதனால் வந்து கெட் அ ட்ரக் ரெசிஸ்ட், எஸ்பெஷலி இன் ப்ரீ ஆப் அசஸ்மெண்ட், ஆஸ்பிரின் குளோபிட்ரோக்கள் எடுத்துக்கிட்டே இருப்பார். சார் இது கேட்டான சிம்பிளாக சொன்னேன், நீ கேட்கல நான் சொல்லலை, அவ்வளோதான் முடிஞ்சு போச்சு. ஸோ தீஸ் ஆர் ஆல் சம் ஆஃப் த ட்ரக்ஸ். தென் coming to the causes எடுத்துட்டோம் அப்படின்னா most 90% of the secondary hypertension and resistant hypertension is from the kidney. நம்ம ஆள் வெங்கட்ராமன் தான், சரிங்களா. ஸோ ரீனல் வாஸ்குலர், ஸோ ரீனோவாஸ்குலர் ஆர் ரீனல் இல்லை அதெல்லாம் சொல்லலாம்ப்பா, அதெல்லாம் கிளாஸ்மேட் தான்ப்பா. ரீனோவாஸ்க் இஸ் மை நெய்பர் ரூம், நெய்பர்ஹுட் இன் ஹாஸ்டல். ஸோ அதனால் ஐ ஹாவ் ஆல்வேஸ் ப்ரிவிலேஜ். I have every privilege to question everyone. Renovascular and renal parenchymal. Then endocrine causes, Kahn syndrome. இதெல்லாம் இந்த ஃபிசிஷியன்களுக்கு ரொம்ப பிடிக்கும். U wave இருக்கா ECGல உடனே Kahn syndrome, hypertension, U wave in ECG, always think about Kahn syndrome. Then fuchromas, episodic hypertension, headache, இதுன்னா fuchromocytoma. Then there is a weakness, aches and pains, hypertension, always think about hyperparathyroidism. தென் குஷிங் சிண்ட்ரோம், கொஞ்சம் சகப்பா அக்னிஃபார்ம் எரப்ஷன்ஸ் இருக்குது அப்படின்னம்னா கொஞ்சம் பப்பலோ கம்ப் இருக்குன்னு வச்சுங்க, உடனே குஷிங் சிண்ட்ரோம்ட்டுருவான். தென் இது லிட்டில் சிண்ட்ரோம், அப்பேரண்ட் மினரலோ கார்டிகாய்டு எக்ஸைஸ், இதெல்லாம் வந்து பிஜிஸ் பார்த்துக்குவாங்க. தென் க்ளூஸ் டு ஐடென்டிஃபை, ஸோ இதுதான் பேராக்சிஸ்மல் ஆர் பர்சிஸ்டன்ட் ஹைப்பர்டென்ஷன், ஹெட்டேக்கு, டயபோரசிஸ்ன்னு நினைக்கிறேன், டாக்கிகார்டியா அண்ட் காஃபே அலே ஸ்பாட்ஸ், ஆல்வேஸ் திங்க் அபவுட் ஃபியூக்ரோமோசைட்டோமா. Then weight gain, weakness, fatigue, hirsutism, amenorrhea, moon-like faces, buffalo hump, purple striae, Lemanon sticks-னு Bailey-ன் லவ்ல கொடுத்துருப்பாங்க, சரிங்களா. அது இருந்தால் குஷிங் சிண்ட்ரோம். அண்ட் இன்டேக் ஆஃப் கார்டிகோஸ்டெராய்ட் டேப்லெட்ஸ். தென் ஹைப்பர் நேட்ரிமியா, ஹைப்போகலிமியா, மசில் ஃபெட்டிக், திங்க் அபவுட் ஹைப்பர் ஆல்டோஸ்டிரானிசம், அக்ரோமெகாலி, ஹெடேக், ஃபெட்டிக், விஷுவல் ப்ராப்ளம்ஸு, என்லார்ஜ்மெண்ட் ஆஃப் ஹேண்ட்ஸ், இதை என்னது ஸ்டப் லைக் இதாக சிகார் ஷேப்டு ஃபிங்கர்ஸ் இருந்தது அப்படின்னம்னா அக்ரோமெகாலி. தென் ஹீட் இன்டாலரன்ஸ், வெயிட் லாஸ் அண்ட் டாக்கிகார்டியா, ட்ரெமர்லெஸ், ஃபைன் ட்ரெமர்ஸ், அதுன்னு தான் ஹைப்பர் தைராய்ட்ஸ் வித் ப்ளஸ் ஆர் மைனஸ் தைராய்டு கிளாண்ட் என்லார்ஜ்மெண்ட். தென் கிட்னி ஸ்டோன்ஸ், ஆஸ்டியோபோரோசிஸ், லெத்தார்ஜி, டிப்ரெஷன், இந்த ஹைப்பர் பேராதைராய்ட்ஸ். இப்போ நமக்கெல்லாம் பெட் ஸ்கேன் வந்துருச்சு, அதனால் ஈஸி. ஒரு 12,000 ரூபாய் கொடுத்து பெட்டை பண்ணிட்டு வந்தோம்னா எங்கெங்கே கலர் ஜாஸ்தியாக இருக்கோ அங்கெல்லாம் மெட்டபாலிக் ஏரியா ஜாஸ்தி. ஸோ யூ ஐடென்டிஃபை. ஸோ முதல் மாதிரி எல்லாம் கிடையாது. இப்போ எதுனா ஒரு பெட்டை போட்டுருவோம் அப்படின்றோம், சரியா? தென் ஸோ அகெயின் ரீனல் ஆர்டரி, ரீனல் சிஸ்டாலிக் அண்ட் டயஸ்டாலிக் ப்ரூயிஸ் இந்த ரீனல். இப்போ நம்ம ஆஸ்கல்டேஷனே விட்டுட்டோம் கோவிட் வந்ததுக்கப்புறம். அல்ட்ராசவுண்டு வித் இது வாட் யூ கால் ரீனல் வெசல் டாப்லர்ஸு. ஸோ அதனால் வந்து அப்டமன் பார்க்குறதும் விட்டுட்டோம். அதில் வேறு ஐ எம் நாட் வில்லிங் ஃபார் அப்டாமினல் எக்ஸாமினேஷன் வேறு. ஐயா ஆஸ்பத்திரிக்கு வர்றவங்கிட்ட நம்ம கேட்டு நீ வர்றீங்களா ஆஸ்பத்திரிக்கு, உங்களை எக்ஸாமினேஷன் பண்ணுறதுக்கு பர்மிஷன் கொடுங்கன்னு கேட்குற சொசைட்டிக்கு வந்துட்டான். அவன் வர்றதே அவன் வியாதிக்கு. இப்போ வந்து நம்ம எஸ் ஐடு எல்லாரும் ஒத்துக்கிறீங்களாப்பா? அது மாதிரி இருக்கிறதுனால ப்ரூயெல்லாம் எங்கே போய் கேட்குறது? முடியவே முடியாது. Some of the bruits are audible only to the chief. சரியா? You say there is no audible, then you will be failed. ஸோ அதனால் வந்து ஏய் அப்பா இது இப்படி தான்ப்பா தமாஷா தான்ப்பா இருக்கும். கிளினிக்கல் லைஃப் அப்படி தான் சரிங்களா? எவாலுவேஷன் ஆஃப் ரெசிஸ்டன்ஸ். தென் கம்மிங் டு த தேர்ட் அனதர் காம்பனண்ட் இஸ் ஃபர்ஸ்ட் கன்ஃபர்மேஷன். எப்படி? பிபி above 130/80, டேக்கிங் 3 or more drugs +1 diuretic. அந்த ட்ரக்கில் வந்து வேற ஒன்று கால்சியம் சேனல் பிளாக்கர், ரெனின் ஆஞ்சியோடென்சின் பிளாக்கர், வேண்ட டயூரிட்டிக். மேக்ஸிமம் பர்மிசிபிள் டோசேஜ். அப்போனா ஒவ்வொரு மாத்திரைக்கும் ஒவ்வொன்று மேக்ஸிமம் டோஸ் எவ்வளவு இருக்குன்னு தெரிஞ்சுக்குங்க. அதுக்கப்புறம் கன்ஃபர்மேஷன் ஆஃப் அதரன்ஸ். மாத்திரை சாப்பிட்றானா, ஒரு பில் கவுண்ட்டு, ஸ்ட்ரிப்பு கவுண்ட்டு, அது என்னென்னமோ சொல்லுவாங்க. அதெல்லாம் நீங்கள் பார்த்துட்டு இல்லை வீட்டுக்காரிக்கிட்ட கேட்டுருங்க. சிம்பிளான விஷயம். சாப்பிட்றான் ஐயா அவன் வீட்டுக்காரன் அப்படின்னு கேட்டுருங்க. மேல் பேஷண்ட் சொல்லிட்டு ஃபீமேல் பேஷண்ட்டை வந்து ஃபீமேல் டாக்டர் கோச்சிக்காதீங்க. ஸோ ஃபார் அன் எக்ஸாம்பிள் சரிங்களா? தென் பர்ஃபார்ம் 24 hours. திஸ் இஸ் ஹவ் டு. பட் அது எக்யூப்மெண்ட்டு வந்து கார்பரேட் ஹாஸ்பிட்டல் ஒரு பிக் நர்சிங் ஹோம்ஸில் வச்சுருப்பாங்க. இல்லைன்னா வீட்டில் வச்சுக்கோங்க. சிம்பிள் ஹோம் பிபி அப்பரேட்டஸ். பேட்டரியை மாற்ற சொல்லுங்கள். முக்கியமான விஷயம். அவன் 10 வருஷத்துக்கு முன்னாடி வாங்கின பேட்டரியை வச்சுருப்போம், ரெக்கார்டே கரெக்டாக வரலம்பா. ஸோ whenever you ask monitor the BP, change the battery. அதுக்கப்புறம் செக் பண்ணுங்கன்னு சொல்லி. தமாஷா இருக்கான்னு தெரியல, பட் திஸ் இஸ் வாட் ஐ ப்ராக்டிஸ். தென் அசஸ் ஃபார் அதே தான் பழைய தான் குஷிங் சிண்ட்ரோமு, அப்ஸ்ட்ரக்டிவ் அதெல்லாம் பாருங்கள். அதுக்கப்புறம் வந்து அசஸ் ஃபார் டார்கெட் ஆர்கன் டேமேஜ். இது வந்து ரொம்ப முக்கியமான விஷயம். ஃபண்டஸ்கோப்பி ஐ பிலீவ் மோஸ்ட் ஆஃப் த ஃபிசிஷியன்ஸ் அந்த ஆப்தால்மாஸ்கோப்பி மதுரை மெடிக்கல் காலேஜில் ஐ பிலீவ் ஸ்டில் ஃபண்டஸ் எக்ஸாமினேஷன் இஸ் கெப்ட் as a ஷார்ட் கேஸ்ன்னு நினைக்கிறேன். பட் ஐ எம் இன்ட்ரெஸ்டட். ரெட்டினல் எக்ஸாமினேஷன் செய்யுங்க. அதுக்கப்புறம் எல்விஹெச்சுக்கு சிம்பிளான வந்து ஏபிக்கல் இம்பல்ஸ் பார்க்கலாம், மர்மர் பார்க்கலாம். அது இல்லை அப்படின்னா இப்போ எக்கோ டாக்டர்கள் இருக்கார்கள், எக்கோ செஞ்சுடுங்க, சரிங்களா? அடுத்தது யூரின் அனாலிசிஸ், சிம்பிள் யூரின் அனாலிசிஸ். நான் நெஃப்ராலஜியில் ஒர்க் பண்ணப்போ என் சீஃப் ஒரு பேஷண்ட் ரீனல் ஃபெயிலியர் ஃபஸ்ட்டு டைம் வித் டார்கெட் ஆர்கன் டேமேஜ்னால் முதல்ல அவருக்கு வந்து யூரினை காமிச்சாகணும். முதல்ல பேஷண்ட் யூரின் போகிறானோ இல்லையோ அவன் யூரினை பிடிக்கணும். அதை வந்து நான் ஒரு கருப்பையான்னு ஒரு லேப் டெக்னீஷியன், ஏன்னா அவனை அப்படித்தான் கூப்பிடுவோம் நாங்கள். கருப்பையா ஒரு யூரின் பாரியா அப்படிம்பா. அவன் கொண்டு வந்து யூரின் எடுத்து இப்போ கொயாகுலேஷன் காமிச்சு என் கண்ணு முன்னாடி காமிக்கணும். அதை கொண்டு போய் நான் சீஃப்கிட்ட காமிக்கணும். இது செய்யலைன்னு வச்சுங்க, அன்னைக்கு அவர் வந்து எனக்கு துவைச்சு காய போட்டுருவா அப்படி. பட் அஃப்கோர்ஸ் இட்ஸ் ஆல் சீனியர் பீப்புள் அண்ட் ஐ ஆல்சோ லவ்ட் இட். பிகாஸ் நெஃப்ராலஜியில் வேலை செய்யணும்னா வந்து அந்த மைண்ட் செட்டோட வேலை செஞ்சு இட்ஸ் என்ஜாயபிள் இது. ஸோ ப்ரோட்டீனியா, ஃப்ராங்க் ப்ரோட்டீனூரியா ஆல்வேஸ் இண்டிகேட்டிவ் ஆஃப் அ கிளாமருலர் டிசீஸ். வேறு ப்ரோட்டீன் எங்கிருந்து வராது. ஸோ தட் மீன்ஸ் ரீனல் முடிஞ்சு போச்சு. அதுக்கப்புறம் டயாலிசிஸ் ஒன்று போட்டுட்டு ஒரு அல்ட்ராசவுண்டை டிசைட் பண்ணோம்னா மகனே நீ ஒன்று எம்ஹெச்டிக்கு போ இல்லை டிரான்ஸ்பிளான்ட்டுக்கு போன்னு அனுப்பிச்சிடலாம், சரிங்களா? தென் பெரிஃபரல் our teachers start, I always used to start with the examination at the foot of the patient. மகாபாரதத்தில் கண்ணன் போய் பார்க்கறக்கு அர்ஜுனனும் துரியோதனனும் போகிறப்போ துரியோதனன் ராஜாவல்லவா தலைக்கிட்ட போய் நின்றுக்கிட்டான். நம்ம இதாகத்தான் இருந்தார், கால்கிட்ட போய் நின்றுக்கிட்டாரு. ஸோ ஹூ வில் ஃபஸ்ட்டு நம்ம தூங்கிட்டு இருக்கிறப்போ முழிக்கிறப்போ காலை பார்ப்போமா தலையை பார்ப்போமா? காலை தான் பார்ப்போம். ஸோ ஹீ காட். ஸோ யூ ஸ்டார்ட் வித் த ஃபீட் ஆஃப் த பேஷண்ட் எக்ஸாம். ஸோ ரெண்டு பக்கமும் டார்சாலிஸ் பீடிஸ் பார்த்தீங்க அப்படின்னம்னா மேட்டர் ஓவர். பெரிஃபரல் வாஸ்குலர் டிசீஸ் இருக்குது, அத்தெரோஸ்க்ளரோசிஸ் பாசிபிலிட்டிஸ், யூ கேன் கோ ஹெட். ஸோ திஸ் இஸ் த மெசேஜ் ஐ வுட் லைக் டு கிவ். ஓகே, அதில் போய் அப்புறம் ஆங்கிள் பிரேக்கில் இன்டெக்ஸ் எல்லாம் அப்புறம் பார்த்துக்கலாம், விடுங்க. அப்புறம் இப்போ நம்ம ரேடியாலஜிஸ்ட் நிறைய பேர் இருக்காங்க, அழகப்பன் எக்ஸெட்ரா எல்லாம் இருக்காங்க. ஸோ யூ கேன் ஆஸ்க் them to do a Doppler study also. So they will also refer the patient to you. Then management. So exclude other causes including secondary etc. Then ensure low sodium diet. இந்த லோ சோடியம் டயட்னா 4 கிராம் 4 to 6 grams ஆஃப் சோடியம் நம்ம வீட்டில் அப்படி சமைக்க முடியாது. நெவர் அட்வைஸ் எ செப்பரேட் குக்கிங் ஃபார் அ பேஷண்ட் இன் யுவர் ஹோம். ஏன்னா மோஸ்ட் ஆஃப் த பேஷண்ட்ஸ் வந்து பிரெட் வின்னராக தான் இருப்பான். அவனுக்கு தனியாக சாப்பாடு போட்டோம் அப்படின்னோம்னா அவன் வந்து அவனுடைய ஈகோ ஹர்ட் ஆகும். முதல்ல தெளிவாக தெரிஞ்சுக்குங்க. வீட்டுக்கார அது அண்ட் ஆல்சோ வீட்டில் 2 சமையல் செய்கிறதுங்கிறது இருக்கிறதுலே கஷ்டமான விஷயம். It's very difficult. So for a patient it should be a secondary prevention. For other people it becomes a primary prevention. ஸோ நான் ஏன்னா இந்த கஷ்டத்தையெல்லாம் நான் வாழ்க்கையில் கல்யாணமான பிறகு அனுபவிச்சதுனால சொல்கிறேன். என்னுடைய ஃபாதர் இன்லா வில் நெவர் டேக் சில்லிஸ், அதாவது வந்து ரெட் சில்லி க்ரீன் சில்லி எடுத்துக்க மாட்டார். அவருக்கு வந்து பெப்பரில் தான் வந்து காரம் வேணும் பாரு. ஸோ வி ஹாவ் பெப்பர் காரத்தோட ஒரு சமையல், சில்லி காரத்தோட சமையல், 2 இது இருக்கும். 2 சாம்பார் வரும், 2 சட்னி வரும். ஸோ அதனால் வந்து அது அவருக்கு ஒரு இது, நான் காரம் சாப்பிடல நீ சாப்பிட்றேன் பாரு, கோச்சுக்குவார். அதே விஷயம் வந்து இமேஜின் இந்த ஃபேமிலி ஒரு இது. அப்புறம் அந்த ஹவுஸ் ஒய்ஃப் செய்கிற ஒய்ஃபுக்கு வந்து எவ்வளோ ஸ்ட்ரெஸ்ஃபுல்லாக இருக்குன்னு தெரியுங்களா? ஸோ நெவர் அட்வைஸ் தனியாக சாப்பாடு செய்யுங்கன்னு சொல்லி என்னைக்கு அட்வைஸ் பண்ணாதீங்க. எல்லாருக்கும் ஒரே சாப்பாடு, நம்ம பையன் சாப்பிட்றது தான் நானும் சாப்பிட்றேன் அப்படின்னு சொன்னோம்னா அது வந்து அந்த ஸ்ட்ரெஸ்ஸை வந்து குறைக்கிறது. அப்புறம் 4 கிராம் நம்ம நெஃப்ராலஜி பேக்கெட் போட்டு கொடுத்துருவாங்க, 4 கிராம் சால்ட். எங்கே போய் நம்ம ஆட் பண்ணுறது? நம்ம வந்து நம்மளுடைய சால்ட் எல்லாமே வந்து குக்கிங்கோட சேர்த்துறது. அப்ராடில் ஸ்ப்ரிங்கிள் த சால்ட் அண்ட் ஈ கேன் ஈட். அவனும் இப்போ சால்ட் அப்படி தான் நம்மளை மாதிரியே சேர்த்துக்கிறான்னு நினைக்கிறேன். ஸோ ஆல்வேஸ் ஒரு சிம்பிளான ஃபார்முலா, நம்ம எல்லாருமே ஹேண்ட்ஃபுல் ஆஃப் சால்ட்டு தான் போட்டு இது பண்ணுறோம். ஸோ அதை வந்து 50% ஆக்குங்க. நம்பர் 1. நோ, அப்புறம் சாப்பாட்டுக்கு சால்ட் கிடையாது, நோ ஆடட் சால்ட் ஃபார் கேர்டு. அப்புறம் வந்து அப்பளம் ஊறுகாய் கருவாடு இது கிடையாது. ஸோ இதை ஃபாலோ பண்ணிங்கனாவே மெஜாரிட்டி ஆஃப் த டைம் யூ அச்சீவ் த சால்ட் இன்டேக். வேணும்னா பசங்களுக்கு வேணால் கொஞ்சம் ஆட் பண்ணிக்கிறேன், ஸ்ப்ரிங்கிள் பண்ணி செஞ்சுக்கலாம். பட் நெவர் அட்வைஸ் எ செப்பரேட் குக்கிங் ஃபார் த பர்சன் ஹூ இஸ் டு ஃபாலோ சால்ட் ரெஸ்ட்ரிக்டட் டயட். இட் பிகம்ஸ் அன் இஷ்யூ. இது அதே போல் இந்த முட்டையில் வெள்ளையை சாப்பிடுங்கன்னு சொல்லிட்டு எல்லோவை சாப்பிட்டு நம்ம வீட்டுக்காரம்ப எல்லோவாக சாப்பிட்டுட்டு இருக்கோம். ஸோ அதுவும் வேணாம், சரிங்களா? ஸோ தீஸ் ஆர் ஆல் சம் ஆஃப் த அட்வைஸ் ஐ ப்ராக்டிஸ். தென் ஆப்டிமைஸ் 3 ட்ரக் ரெஜிமெண்ட். ஸோ என்னென்ன? ரெனின் ஆஞ்சியோடென்சின் பிளாக்கரு, கால்சியம் சேனல் பிளாக்கர், மேக்ஸிமம் பர்மிசபிள் இது டயூரிட்டிக்ஸு. டயூரிட்டிக்ஸ் வந்து டிபெண்ட்ஸ் அப்பான் வால்யூம் ஓவர்லோடு இருந்தால் தைசைடு யூஸ் பண்ணாதீங்க, ஃப்ரூசிமெண்ட் தான் யூஸ் பண்ணணும். I personally don't use thiazides, though people differs, because my personal experience with thiazide is catastrophic. So அதனால வந்து I never use thiazide diuretics as an antihypertensive in my practice. But guidelines says use, ரைட்டுங்களா? So I leave it to your choice. Then substitute optimally dose. முடிஞ்சு போச்சா? Then if everything is not okay, then add spironolactone and eplerenone. I believe cardiologists are fond of these 3, that nephrologists will not add these 2 because they are worried about potassium. I am not worried about potassium. Then BP still not on target. Then check heart rate, add beta blocker, metoprolol, bisoprolol or combined இது. Still BP வந்து வரல அப்படின்னம்னா then hydralazine, அதெல்லாம் good old drugs. Then minoxidil. So these are all the stepwise approach of treating the disease. இதெல்லாம் வந்து tailor made to your உன்னுடைய ஸ்டைல், உனக்கு பிடிச்ச மருந்து. அப்புறம் நீ வச்சிருக்கிற டைஅப் வித் பார்மசூட்டிக்கல் கம்பெனி, சரி இதெல்லாம் நிஜம் ஒன்று. அடுத்து வந்து நீ வேலை செய்கிற ஆஸ்பத்திரியில் பர்ச்சேசிங் பாலிசி. நீ எவ்வளோ பெரிய ஆளாக இருந்தாலும் சரி, அங்கே ஒரு டிப்ளமோ படித்தவன் தான் வந்து உன்னுடைய பர்ச்சேசிங் பாலிசியை டிசைட் பண்ணுவான். ஸோ யூ ஆக்ட் அக்கார்டிங்லி. ஓகே. தென் டயட். So 24-hour dietary recall is a direct dietary assessment tool that consists of a structured interview in which participants are asked to recall all food and drink they have consumed in the previous 24 hours. So it's left to your discretion of. So these are all the food grains. Grains, the whole is whole grains, not refined grains. Meats, poultry, 6 or less. Vegetables, பூமிக்கு மேலே விளையிற வெஜிடபிள்ஸ் நோ லிமிட்ஸ், பூமிக்கு கீழே இருக்கிறது மாடரேஷன். ஃப்ரூட்ஸ் வந்துங்க தயவு செஞ்சு ஆப்பிளே 24 மணி நேரம் சாப்பிடாதுங்க. சீசனல் ஃப்ரூட்ஸ் எந்த டெக்ஸ்ட் புக்லையும் வந்து இந்த பர்டிகுலர் ஃப்ரூட்டுன்னு சொன்னதே கிடையாது. சீசனல் ஃப்ரூட், நம்ம ஊரில் கிடைக்கிற ஃப்ரூட்ஸ், சரியா? ஓகே, நம்ம ஊரில் விளையணும், நேட்டிவ் ஆஃப் அவர் சாயில், அதுதான் முக்கியமான விஷயம். தென் லோ ஃபேட் ஃப்ரீ டைரி ப்ராடக்ட்ஸு. Then fats, oil எது வேணாலும் எடுத்துங்க, depending upon their socio-economic status. All oil are good. ஆயில் கரெக்டாக அளவாக சேர்த்துக்கிறான்னு சாப்பிட்டோம்னா எப்படின்னா, நீங்கள் தோசையாகட்டும் இல்லை காயாகட்டும், அந்த காய் அப்படி தொடணும், தொட்டு உங்கள் கை விரலில் ஆயில் இது இருந்ததுன்னா அது வந்து ஆயில் எக்ஸஸ். அது இல்லாமல் தோசை சுட்டு தர்றதுக்கு நீங்களும் கற்றுக்கு, உங்கள் வீட்டுக்காரமாக கற்றுக் கொடுத்துருங்க, முடிஞ்சு போச்சு. திஸ் இஸ் ஹவ் அதெல்லாம் ஒரு ஸ்பூன் போட்டாலும் சரி, தொட்டோம்னா ஆயில் இது வந்து ஸ்மியர் இருக்கக்கூடாது உங்கள் கையில், ரைட்டா? தென் சோடியம் as already told, nuts, seeds, dry beans, peas, இதெல்லாம் depends upon your socio-economic status of the patient. Okay, the success of the complaints of the medicine relate with the socio-economic status of the patient, not with the drug-னுடைய efficacy இல்லை. Okay, then sweets. So the adherence is defined as remaining attached to the medication regimen and is distinct from compliance, which means submitting to a request or wish. So இதெல்லாம் எப்படியாவது மாத்திரை சாப்பிட்றேனான்னு பார்த்துக்கிற அது adherence இருக்கணும். Then identification of patients with inadequate adherence among those will avoid unnecessary and potential harmful treatment. So இது நம்மளை பற்றியே நம்மளே திட்டிக்கிறது தான், விட்டுருங்க. So other hands, some of the methods, pill count, self-report, prescription of refill data, and urine and blood measurement of drugs and metabolites, and dosing consideration. So these are all some of the thing. Then new year thing, கடைசியில் ஒரு இதுக்கு வந்து renal nerve ablation. I believe some of the centers in doing, எங்கள் ஊரில் வந்து KMCHல they are doing renal nerve ablation therapy for hypertension. Then carotid baroreceptor, இதெல்லாம் வந்து புதுசு கிடையாது. அந்த காலத்தில் வந்து ஹைப்பர் மருந்து கண்டுபிடிக்காத காலத்தில் செஞ்சுட்டு இருந்தது தான். Now it has coming into the work. It's a highly complicated and results are promising. I think I am not the expert to tell all those things. With this I conclude session. I think ஒரு 2 ஸ்டால்வார்ட்டுக்கு அடுத்து மூணாவதா ஒரு ஆள் I think I have justified it and I am completing. Thank you for the opportunity. நான் ஒரு ஸ்டூடெண்ட்டாக இருந்து அங்கே உட்கார்ந்தது 25 வருஷம் கழிச்சு இங்கே வந்து பேசுகிறேன். I am proud of it. Thank you for the opportunity.
We welcome our Dean, Professor Dharmarajan sir, to our CME. And thank you, Sivakumar. It is a very interesting presentation. We learned a lot from you. Now I invite Dr. Xavier, Professor of Forensic Medicine, Wales Medical College, and a very good friend of Sivakumar, to honor Sivakumar on the stage. And I invite Dr. Sukumari, Professor of Microbiology, Madurai Medical College, to join Xavier to honor the speaker. Thank you, Sivakumar.
Now let us move on to the inaugural function. I request our beloved Dean sir to come over to the stage. I request our medical superintendent, Dr. Kumaravel sir. Next I request President of Alumni Association, Dr. Tamil Selvi. Dr. Alahappan, Chairman, Rubitinum 84. Secretary, Dr. Xavier. Treasurer, Dr. Sundar. to come over to the stage. Now, may I request Dr. Tamil Selvi to welcome the gathering. So let us start with Tamil Thai Valthu. நீராறும் கடலொடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்வரத கண்டமிதில் திகழும் அதிசிறந்த திராவிடனல் திருநாடும் தரக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே. Thank you. Now I request Dr. Tamil Selvi to welcome the gathering.
For the past 3 months to conduct the CME every month. Welcome, sir. And I welcome our medical superintendent, sir, who generously allotted this auditorium today for us. Welcome, sir. I stand with the privilege as the president of the prestigious Alumni Association of Madurai Medical College and prestigious. I welcome Dr. Saravanan, sir. RMO onto the stage, please. Alumni Association's president in this stage. I would say Alumni Association of Madurai Medical College is a very, very, very strong alumni association, and we have taken over in this year, and our function, grand function, will be on December 14th and 15th, which is Rubitinum 24. From 84, 2024, 40 years. The first batch is 54. Now it is 2024, 70 years. So we called it as a Rubitinum 2024. And our batch is named as a Vidugal 84. Vidugal 84, because we have learned from that and we want to serve it back. And with this, actually I should thank our Dean. Today is Medicine CME by the Medicine Department of Madurai Medical College, which is going on in the 6th floor of our college. In spite of that, it is the retirement CME of our beloved Dean. In spite of that, I actually thank Dean to come over here to inaugurate this 7th CME of Vidugal 84. I thank you, sir. I welcome you all once again.
Now I request Dr. Alagappan to brief about our Dean, sir.
Good morning, everyone. It gives me great pleasure in introducing a person who's known to you all. Professor C. Dharmaraj is a very dynamic person. He is a dual degree holder. He is a physician cum pediatrician and a great medical teacher. Dharmaraj sir is known to us from our first year. Sir did from 1982 batch from Madurai Medical College. He did DCH from Stanley Medical College from 90 to 92. Then 94 to 95 to 98 he did MD General Medicine from Madurai Medical College. And 2001 he entered Madurai Medical College, and he is completing 33 years of government service this year, and will be superannuating on 31st of August. And another very great and rare privilege is he has completed 25 years of service in Madurai Medical College as a teacher. Sir has been involved in several fields apart from medicine and pediatrics and teaching. he has held several administrative positions, and he has been a treasurer of Indian Association of Pediatricians, and he was treasurer for 15 years in Association of Physicians of India, and he has been a chairperson and delivered several lectures in APICON, and he was a chairperson of APICON in Gujarat. And another sir is a very busy practitioner. He is a leading practitioner in Natham and all the villages in and around Natham, pediatrics as well as. And another one specialty about him is he practices purely internal medicine in one place and pediatrics in another place, and he excels in both the places. And sir has been involved with Tulir, like most of the medical college students will be knowing about Tulir. It's an organization which is in Madurai Medical College, which tries to help Madurai Medical College students from poor background. And he has been instrumental in identifying and supporting them. And I am proud to say that Tulir has burned the hostel fees, tuition fees and other books, everything for more than 28 students so far. So we appreciate and we salute your service, sir. And as a 84-year, sir has been always forthcoming and used to give all support what we needed. And he used to support us and encourage us in conducting this Rubitinum 2024. And sir, we thank you wholeheartedly for all that you have done to this institution. And as from Virudugal 84, we feel privileged to honor you, sir. Thank you, sir.
Honoring of Dean. Thank you, my dear friends. Now may I request our Honorable Dean, sir, to address the gathering and say a few words.
Respected MS sir, RMO sir, my friends, Dr. Sundar, Xavier, my General Medicine and Sivakumar, and the organizing committee, Epidemiology madam, Geeta madam, and all other. First of all, thank the organizing committee for the given the opportunities. So this alumni actually is inaugurated by the 10 years back only, and continuously will celebrate the alumni festival. Last year our batch is conducted. I think the last batch is the largest number, I think, participated in the last year in our batch. Because our students are more. Previously 150, Now 250 students, the number of participants is more, and very academic is present. So why the academics is very important? The refresh of our knowledge is in today itself. Also, I am reading minimum 10 to 15 minutes. That way, I usually the reason, advantages, and everything. So your job is mainly daily reading, reading. So today topic is medicine. Topic. So resistant hypertension. The definition of the resistant hypertension, you know, the BP not controlled even after the first line drugs, 3 drugs. Minimum 3 drugs, the BP will be not controlled. This is the definition. So basically, why the word we given the importance of the BP? Suppose you control the BP, you prevent stroke. The first thing is you prevent stroke. What is important? Another. So BP will not show any complaints except in hypertension, emergency or urgency. Till that time, the patient not complain single word, whether is a sweating, headache, giddiness, anything will not present. Incidentally, only routine checkup, the BP will be possible to the record. So the bedside test is not the recording the BP fundus examination. If shows the hypertension retinopathy, definitely the patient is hypertension is present. Auscultation. The apical impulse is what apical impulse? Heaving. Always you suspect it is a hypertension. The second sound is important. Not only the second sound's character, whether it's a patient is on treatment or control, the characters of second sound is very important, whether soft or loud. So no need for taking any other test. This is everything's only with only stethoscope and ophthalmoscope. That's enough. யூரியா பார்க்கணும் அவசியம் இல்லை, கிரியாட்டின் பார்க்கணும் தேவையில்லை, இசிஜி பார்க்கணும் தேவையில்லை, எதுவும் ஹோல்டர் ஆல்ட்ருமெண்ட் தேவையில்லை. ஸோ சிம்பிளிஃபை so the common problem, the grouping of the drugs A, B, C, D, whether it's AC inhibitors or beta blockers or calcium channel blockers, diuretics. This is the simplify on central acting drugs. I think Shivakumar sir discuss about the everything. So AC inhibitors, AC, ARB, AC, indication, contraindication. Any patient with the cardiac and good LV function, young age group, usually AC inhibitors. Should not combine with the AC inhibitors with the ARB. That is main. And the worst contraindication, CKD. The creatinine level is more than 3.5, creatinine will be, don't give AC inhibitors ARBs. Basically, this is the basic. And diabetes with hypertension, best drug is ARB or AC int. Then absolute contraindications, any isolated stenosis, MS, AS or AS, renal artery stenosis. These situations should not given any drug of AC inhibitors or ARBs. Patient will be for the bronchospasm or severe anaphylaxis will be present. So what is the indication of beta blockers? So beta blockers when should not given? That is very important. Rate control. So rate related to any myocardial infarction, the beta blockers. Nowadays is the cardiovascular problem, selective beta blockers are now available. So many cardiovascular beta blockers. Previously we should not given 3C, any beta blockers. Complete clot plaque, COPD, then students, final years, pre-finals, anybody's. What is another 3? Congestive failure, CCF. So CCF also now the selective beta blockers can be given, Radiology is available. So previously beta blockers are different. So young married peoples usually we not advise any beta blockers. So importance or anything which is possible. Then C, calcium channel blockers. Again, in the all principal angina, anginal pectoris, everything is present. Again, is the only problem is agiospermia very common in case of amlodipine. You can very carefully monitoring. Then diuretics. The diuretics is the best drug for the old age persons. You combined with amlodipine and diuretic is best drug. Contraindication again hyperuricemia. Any gout patients should not advisable diuretics. Any diabetic related complications should not advise diacids. So these are the two absolute contraindications. So diuretics is usually given the best drug for the old patient. But the isolated single drugs usually not advisable. Usually the diuretics can be advisable for the combination drugs. Then central actings, isoclonidine, anything, that is only entirely different. So this is a simplified way to select the anti-hypertension in young, the treatment of the patients. Nowadays, the confirmed infection of the hypertension is 24 hours work monitoring only, not for the single recording is not advisable nowadays. Because of this false recording will be possible. So I think it's a call from the our symposium. Thank you very much, sir.
Thank you very much for your kind words, sir. We could see the thirst of a good teacher when you face the students. And though there are few more days, I take this opportunity on behalf of our batch to wish you a happy retired life, sir. Thank you, sir. Now, definitely, sir, definitely. There is no retirement for doctors and a good human being. Definitely, sir. Now, I request Dr. Xavier, Secretary Rubitinum, to deliver a vote of thanks.
டீன் சார் அவசரமாக வெளியில் கிளம்புறதுனால எல்லோருக்கும் நன்றி கூறி விடைபெறுகிறேன். வணக்கம்.
நன்றி. Let us all break for tea.
Tea for 10 minutes.
Assemble back after 10 minutes.
Welcome back, everyone. We move on to the next session by Dr. A. Somasundaram, Additional Director of Public Health, Directorate of Public Health and Preventive Medicine, Government of Tamil Nadu. Dr. A. Somasundaram is one more proud alumni of 1984 batch. He finished his MD and DPH and MAE, and now he is an additional director at Chennai. His areas of interest are maternal and child capacity building, maternal and child health, capacity building, vector-borne diseases control, and non-communicable diseases. A person who is in the public health should be much dedicated and should have a very great leadership qualities, and he is one such example in our batch. And he worked in Chengalpet Medical College as Assistant Professor of Community Medicine and Madras Medical College as Assistant Professor of Community Medicine, and he switched on to the administrative side like Health Officer Karaikudi, Deputy Director of the Public Health Vellore, Deputy Director of Chennai Research Area, and Deputy Director of Public Health Tirupattur, Deputy Director of Public Health Vellore, Joint Director of Public Health PHC, and Joint Director of Immunization, Joint Director of AIDS Control and Blood Safety, Joint Director of Health Education, and Additional Director of Universal Health Coverage, and Directorate of Public Health Additional Director NHM Tamil Nadu in 2019 to 21, and Director Institute of Community Medicine from 21 to July 23. Now he is Additional Director of the Public Health at Chennai till date. And to his credit, he has got many publications and many conferences. He is the invited speaker in the public health side and communicable diseases side. And as far as I know, he is my best friend, our classmate, and who has got much commitment and dedication in his work. And over to Somasundaram. His topic is on physician through public health lens.
In fact, I am searching for Sivakumar. Okay, good afternoon. By the time Dr. Sivakumar is, because why I am searching for Sivakumar is he is the one he communicated to me, and also ensured that I am presenting here. 2 months back itself he called me, and he in fact on behalf of the committee Rubitinum, Kumar, waiting for you. First I will start with the way in which he presented. It's a very lively presentation. He used to be like what I saw in 84 to 89, 90 is the same Sivakumar. And all friends for that matter. Everybody is same and everybody is still friendly, and this is the 40th year since we joined. In fact, I remember the day September 3rd we joined. August 28th we paid the fees. Huh? September 3rd in Nanakiran. 3rd. First day I lost my coat. First day I was in ragging for 9 hours. So those days still we are remembering. And this is a room where I presented a seminar topic, dysfunctional uterine bleeding. At that time I did not know what is dysfunctional uterine bleeding, and I was forced to present on that. Now I have இது என்ன சிவகுமார் சொன்னது சொல்லலையே, ஸ்டெத்தில் வந்து only professors can hear the murmur. That is very true, because initially we use our stet to hear the murmur. Then we place the steth on the same point and change the ears. And even then we will not recognize. ஆனால் வந்து எல்லாம் we pretend as though we are hearing. Are you able to relate to your experiences? Yes, thank you. So I loved one person, I married one person, and I was forced to marry another person. The loved person is pediatrics. I did not get it. One side love. Yes. And my arranged marriage was with my wife, lovable wife, Dr. Dharmambal, everybody knows her. And the forced marriage was with public health. No other go. So, since I did not love public health and I did not read community medicine properly, the God maybe gave me a good punishment to be with public health. In fact, Sivakumar is the best person to be a public health person. எதை கேட்டாலும் கம்யூனிட்டி மெடிசனில் ஒரு ஹீவில் இந்த எந்திரன் படம் பார்த்துருப்பீங்கள்ல, ஸ்கேன் பண்ணுவார்ல ரஜினி, அது மாதிரி அவர் ஸ்கேன் பண்ணுவார் கம்யூனிட்டி மெடிசன் புக்கை படிச்சுட்டு போய் அவர் தான் இன்ஃபேக்ட் ஹி கெட்ஸ் அ குட் மார்க். ஸோ ஜஸ்ட் டு செட் அ டோன், எல்லாம் ஸ்கேன் பண்ணிடுவாங்க. Thank you, Sivakumar, and thank you, friends, for giving me this wonderful opportunity. Thank you, committee president, including Alagappan and all. In the topic, you please stay on with me if you like this. Okay, even if you don't like, you stay on with me. No other way. Okay. How a clinician should see diseases in a different perspective is my topic. So I thought of giving a fancy name. It is a physician through public health lens. Okay, that's what we are doing. And many of the doctors who come to service or who do private practice, they are supposed to look into the lens of a public health perspective, but unfortunately many people are not realizing what they are doing. And those who see people in the private practice or private clinics, now I am not talking about the corporate hospital, they are in fact serving the community indirectly or without knowing what is going on for a bare minimum fees, particularly in villages. And also in government hospitals, including primary health centers, secondary care institutions, medical colleges like this, all we are doing a lot of service, but we do not realize unless we are into it. Okay. So you all remember that COVID-19 was declared as a public health emergency of internal You all remember that COVID-19 was declared as a public health emergency of international concern, PHIEC, on 30th January 2020. Before this was declared, everybody told India la irukra climate ku COVID la varadu because it is very hot and sultry and the virus will not survive. But to our surprise, it was declared as public health emergency in India too, and there was a big lockdown on March 24th, 2020. WHO characterized the outbreak as a pandemic, okay, on March 11, 2020. And after 3 years of intensive, in fact it is a war, because the place which was designated to manage the COVID pandemic was called as war room. And after waging 3 years war, finally 5th May 2023, the COVID-19 was declared as no more as public health emergency of international concern by WHO. I started this slide with COVID because you all know about COVID. So most probably you will be knowing what is epidemic, what is endemic, what is pandemic, what is outbreak, everything. I'll touch upon those topics and then we'll go to the topic proper. What is public health? Public health refers to the all organized measures for the population as a whole. Read the last line. All organized measures for the population as a whole. Okay. In between we have promotion, specific prevention, early diagnosis, screening, etc., etc. But what is the difference between a public health person and a physician? Clinical physicians dwell on medications, surgery, and case-based counseling, taper down to diagnosis for management, and they are always engineered to diagnose and treat successfully. Public health physician, whereas works on preventive interventions, immunization campaigns, social interventions, and work on community designs and all components of engineering and environmental sciences, and they are trained to prevent and control. In this way, we'll have a feeling that both are different, but there is no difference in the intention. Both are doing the same work, but the population served is individual and community. The differences are deep rooted in the history. That's what I told, that when we read community medicine, we'll always give preference for ENT, opthal, forensic medicine, clinical medicine, surgery, OG, and community medicine will always be in the last. But there will be failures in community medicine more than any other subjects. When not now, because in the recent days we cannot fail a student, any student. This is the way the exam system is structured now. So those days, yeah, very difficult to fail. But somebody wage a war and failed themselves. Some students, few students. Okay. The growing demand for public health training with the existing curricular from, you all know that you have a what is that, family adoption program in medical colleges, which was recently introduced from the first year onwards. Those things we have already done. When we go to the community medicine posting in first clinics, second clinics, I don't remember exactly. We were asked to do a household survey, and now it is structured through and delivered through MCA, those concepts. And now there is a growing recognition of thrust of integrating medicine and public health. Public health, and one thing you should understand, that public health is not government. It is the word public is for the public and not with the public sector hospitals. So public health is different, public institutions are different. What is the public health role by physicians or through physicians? They are indirectly contributing for promoting national policies. They are doing research to develop and test policies and strategies. They are indirectly building the capacities, now develop new health interventions, and also train health workers. Every doctor is a trainer. Every doctor is a teacher. So they are. What is the difference? How can this public health and how to bridge the gap between the individual patient care and population level health care? I don't want to go get you into the theory, but I'll just read out the titles alone. Surveillance and reporting. You do daily surveillance. Only thing is there is a gap in the reporting because we do not know much about the importance of reporting. Whom to report, how to report, what to report, we do not know. Vaccination and prevention. The government is providing vaccination. The private doctors are giving vaccination, the hospitals vaccination is being done. And also, as the previous speakers were talking on health promotion, like food, exercise, physical activity, food habits, etc., salt restriction, everything, all is for health promotion. And once this fails, at least we have to do the screening early and diagnose. Okay. So that the patient will not go into complications and get themselves into disability. So screening and early detection is another component of public health, which all physicians are doing on day-to-day basis. And also health education and promotion. The patient-based counseling are done by the physicians, whereas the counseling, structured counseling or community-based counseling are done by the public health physicians. And there is community engagement, apart research and evaluation, collaboration and partnership, policy development and advocacy. All physicians are somehow the government is forming separate committees for different expertise group. For example, if you want to reduce the maternal death, there is a separate committee. If you want to prepare a protocol for hypertension, there is a separate committee. If you want to prepare a protocol for chronic kidney disease, there is a separate committee. All these are in the public health perspectives, but the experts are physicians. So one day or other, you will become a physician, but you will get into the public health perspective of different diseases. The public health perspective is preparing national policies, promoting different initiatives, and implementing different strategies for bringing down diseases, promoting health, etc. Okay. I'll come to this slide. What are the roles of significance by the public health, or in the public health by a physician? The notification, spurt of cases, clusters, new symptomatology, approaches. For example, now we have mpox. What is mpox? How is it spreaded? Suppose who is having monkeypox? How will you screen? Where will you screen? What is the diagnostic methodology? These are the questions for new diseases. Some diseases are re-emerging. Some diseases are nearby state. Kerala is reporting a lot of Nipah cases. What type of strategy we are adopting? Those things we have to know. We are supposed to know. So I'll just introduce these words for just a clarification. Notification. What is notification? Whatever you inform, it becomes notification. Whatever you inform to your higher authorities become notification. Whatever you inform to the government, it becomes notification. Notification helps to assess trend. Suppose if there were no cases of polio in the past 3 or 4 years, then suppose if there is an acute flaccid paralysis or due to polio, then it becomes a talk of the town. Then it becomes an important event to be reported to the higher authorities or to the government. So we have to assess the trend, whether the cases are occurring or not. Notification helps to assess the trend of disease. You would have learnt about, suppose if you have completed community medicine, you have learnt about seasonal trend, cyclical trend, etc. Because dengue shows a cyclical trend. Every 5 years it comes up in big way, and every lot of deaths occur, due dengue morbidity occurs. So such type of trends you have to assess through notification. And the notification helps to elicit response from the concerned authorities. It also facilitates how to stop the transmission. Only if there is information that this mpox, I told you about mpox. Only when you know mpox, you follow certain strategies to stop transmission. So unless there is an information, we do not know what is happening. So now I will show you in the last slide what is happening in Tirchi airport or Madurai airport. Okay. So there is a separate act in Tamil Nadu which is called as Tamil Nadu Public Health Act. It was formulated in 1939. Under that act comes the notification. There are certain 28 diseases which are supposed to be notified. Suppose if a doctor sees a case and they are not notifying the occurrence of the case, then the doctor is liable to be punished. Okay. If the act is promulgated, if the act is implemented strongly, and if the doctor is not notifying any disease among these 28 diseases, the doctor is liable to be punished. Punishment is not, you should not think that punish panna odane arrest panniduvanga, seraila pottuduvanga, thookla appadi illa. There are certain ways of penalizing. They impose penalty. Okay, so these diseases, why these diseases are to be notified? Why they are imposing fine? Because these are likely to get transmitted if not controlled, if not prevented. Okay, so for example, latest our notification was for COVID. Then once mucormycosis came, it was also included in the notification of diseases. So probably if mpox enters into India, then it will be included in the notified diseases. These are likely to get amended every year or as and when there is an epidemic or pandemic. Okay. Then how will you notify? What to notify? How will you see such cases? How will you suspect such cases? There are two types of conditions which will give you new symptoms which you have not read, or which you have read as very rarely this can occur, very rarely that can occur. So these are two diseases which are emerging diseases and exotic diseases. Emerging diseases are new diseases which are native to, maybe native to the country or native to the local religion. Exotic conditions are conditions which are prevalent in other countries but new to our locations. Okay. New symptoms, any unusual symptoms, and symptoms are signs of complications also. Then once you know the symptoms, clinical management is critical, becomes critical. Mortality always evokes public health public concern. See, whenever there is a new disease and the doctor is not able to control, and if somebody dies, okay, then people will start throwing stones or making assaults or making damage to the hospitals, etc. So we have to be very careful in treating the case as well as informing the people or identify new cases. You should develop the acumen of diagnosing new symptoms. Okay, diagnosing or at least identifying new symptoms. And even such events are always politicized. Okay, you know the symptoms, you know how to notify. When will you notify? There will be a spurt in numbers. There will be increase in numbers of certain symptoms or cases. Now, it's a right time to introduce you or reintroduce that what is an epidemic, what is an outbreak. Outbreak is an epidemic of shorter duration covering a limited area. Epidemic refers to the occurrence of disease condition in excess of the usual frequency. I already mentioned 2 standard deviations some slides back, 4 or 5 slides back. So you have to assess the trend. So if it is more than 2 standard deviation of the usual occurrence, then it is called as epidemic. So in excess of the usual frequency in a given area or among specified group of people over a particular period of time. If it occurs for 3 or 4 days and then slows down, then it is called an outbreak. If it occurs for a period of maybe 2 weeks or 1 month or 3 months, then it will be an epidemic. Okay, the same disease, it occurs for a very short time. For example, food poisoning, a cholera epidemic, cholera outbreak. It can be outbreak, or if it is extended for more than 3 or 4 weeks, then it can be called as an epidemic. Then what is a sporadic disease? Sporadic disease occur in isolation. Now, sometimes sporadic event can also elicit public health response. For example, there is one acute flaccid paralysis reported from one of the districts in Tamil Nadu. For the past 20 years, acute flaccid paralysis are being surveilled and regularly being monitored by the WHO National Polio Surveillance Project. That is, it is not polio, it is acute flaccid paralysis. It may be due to polio or may not be due to polio. But polio is eliminated in India, right, Tamil Nadu particularly in 1994. 2016 we have got a certificate of polio eradication of type 2 virus in 2016 itself. 2019 we have eradicated, almost we have eliminated polio. But only thing is, suppose if there is one occurrence of polio, even if it is sporadic, then it becomes a matter of concern. Now we come to the endemic. Epidemic, outbreak, sporadic is different. Endemic is, filaria is an endemic disease. Okay, leishmaniasis is an endemic disease. These are endemic in certain regions of the country or in certain regions of the world. Pandemic, you all know which was the pandemic. Last COVID pandemic, okay. So when it crosses a continent, then it becomes a pandemic. Why do this spurt in the number of cases occur? For example, if you give measles vaccine, it is only 85% effective. 15% always are susceptible, and over a period of time, the 15% accumulate a great number, and the measles epidemic can occur. So increased transmission, new strain or variant, changes in the human behavior, environmental factors, waning immunity. now we are eroding the forest area and building houses, residents in their area, and then we say animals are intruding into the houses. We are already intruded into the forest area, and when leopard or tiger or something comes to, particularly in Kerala, they are frequently reporting this. The residents, the population, humans have eroded into the forest area. Now we are saying that is what is changes in human behavior. We travel a lot, we erode a lot, we get into the forest for livelihood, everything. But we say that animals have eroded into the human area. In fact, we are destroying all the survival possibilities of animals, and so animals are getting into the human area. So these such sort of human activity or non-human activity and the developments have increased the possibility of transmission. So there are always a spurt of numbers, possibility of spurt of numbers, which can be an emerging public health concern. So how do we respond to these spurting cases? Enhanced surveillance. We have to increase the surveillance. Suppose if there is a Nipah virus reported in Kerala, then there are 6 border areas in Tamil Nadu which are bordering Kerala. Okay, in Nagarkovil, Tirunelveli, Coimbatore, Tirupur, the Theni. So similarly 6 areas are brought into the surveillance. So we have to increase the surveillance, and there should be a continued surveillance for any diseases. That's why we have to find about new symptoms. We should know about new symptoms, new diseases. We should be updated. And another response is contact tracing. We did a contact tracing, and you all know the contact tracing was not known to many persons earlier. But once COVID pandemic was there, have a contact tracing. We are giving tuberculosis preventive therapy to those contacts who are exposed to tuberculosis index cases in their households. So testing and diagnosis are responses. Infection control measures, example I put it in the bold, personal protective equipments, social distancing, etc., vaccination, public awareness and education, collaboration and coordination. The collaboration and coordination, you specifically just keep it in your mind. This is between the departments and also within the departments. So physician should not say that this is due to lack of public health measures, and the public health person should not say that this is due to lack of clinical support or clinical acumen. So we have to sit, we have to do we have to prepare lot of SOPs, we have to update the control measures, etc. Then again there is another word called clusters. So increase in numbers, new symptoms, then comes the clusters. What is cluster? Cluster of cases refers to an aggregation of cases of a particular disease or health condition that occurs in a specific geographic area or a population within a limited time frame, within 1 week or within 1 month or within a border area. So it is an indicative of an outbreak or emerging public health problem. What is a characteristic of different characteristics of clusters are there? There is a temporal time, within short time, temporal cluster, geographic clustering area, demographic particular population. So types of cluster, it's a point source cluster or continuous common source cluster and a propagated cluster. So these are the terms which make us not to study community medicine. Okay, but somehow I wish you all to become a public health persons if you don't read community medicine. Okay, so there is another standard 10 steps investigation of an epidemic. Very good. So I don't want to go into that. Examples of clusters: foodborne illness outbreak, clusters of cases linked to contaminated food or water. Respiratory disease outbreak, we all know that COVID and influenza, etc. Vector-borne disease cluster, dengue, fever, chikungunya, there are a lot of things are there. And these increase or cluster occurrence triggers, you can use any term, alerts, it warns, or it flags off an outbreak. It's a start of an outbreak and necessitates public health response. So if you see a patient with acute flaccid paralysis in your clinic, then you have to inform. You have to evoke a public health response that triggers or warns that there is some problem. If there is suppose if there are symptomatologies of mpox and somebody comes from a specific country and they have similar symptoms, then what is that you have to do? You have to notify. And there are approaches. Clinical physician and public health physicians are two sides of a coin. We cannot separate them because I told you that the intentions are not different, the same. We have syndromic approach or clinical algorithm and management algorithm, integrated management algorithm, and there is algorithm for diagnosis. Okay. So for example, if you take fever, okay, so these are the differential diagnosis. If fever with or without accompanying symptoms, scrub typhus, dengue, malaria, typhoid, leptospirosis, KFD. If you have eschar, you have to suspect scrub typhus, anthrax. If there is a non-vesicular rash, then you have to look for dengue, chikungunya, measles, rubella, Zika virus disease. If there is a petechial rash, you have to look for dengue, meningitis, and Congo hemorrhagic fever. And if there is a vascular rash, then again dengue, hemorrhagic fever, and with bleeding, then these are the things. With altered sensorium, again you have to think of malaria, typhoid, meningococcal meningitis, encephalitis, Nipah virus, etc. So this is one flow chart or algorithm which leads you to inform or at least a probable diagnosis or a broad diagnosis with which you have to report only the symptoms. The doctors are not expected to report the diagnosis. Okay, they can tell that I have a patient with rash, I have a patient with petechial rash, I have a patient with petechial rash with bleeding. Then that triggers a public health response. Fever more than 7 days. Only fever, you have to suspect these things, brucellosis, typhoid, Kala-Azar, etc. With respiratory manifestations, tuberculosis, chronic bronchitis, others, etc. Then with gastrointestinal manifestations, typhoid, tuberculosis, brucellosis. With multi-system involvement, then you have to suspect brucellosis and tuberculosis. Similarly for jaundice, you have to classify with fever or without fever, whether it is viral hepatitis A or E, or whether it is drug-induced, scrub typhus, leptospirosis, etc. Again cough, you have a good broad algorithm. Okay. Then diarrhea with less than 2 weeks duration, fever, without fever, with fever or without fever. Then you have these time requirement. Okay. So if you have fever, diarrhea, and diarrhea with blood, without blood. So these are the algorithm to take you to a probable diagnosis. A clinician do a probable diagnosis. A health worker do a suspected diagnosis, suspected disease. And this is a management algorithm. So this IMCA, see the last legend, IMCA stands for Integrated Management of Childhood Illness, and another one is Integrated Community Care Management. Okay, these are algorithms for management. Earlier, the previous 4 or 5 algorithms stand for bringing to for a probable diagnosis. This is for management. Okay, then there is a diagnostic algorithm for lab confirmation. So fever with rash, what is the sample you have to take? Serum. Test for dengue, test for chikungunya. If it is negative, then both are negative, then test for Zika. Why? Can you just relate why these diseases are mentioned here? Somebody can tell. You have taken a sample of serum. You are testing for dengue. You are testing if it is negative. Testing for chikungunya, negative. Then you are testing for Zika. Why? Madam? Vector is same. Okay. So when there is an vector population, then your diagnosis should move towards this. This is an example only. Okay. Right. Now, clinical manifestation of common communicable diseases. This I don't want to go into the details because definitely you will, I can see, I will see a lot of people sleeping. I don't want to go into that because whenever we read a disease, then we will start, interest start பண்ணோன incubation period போம். போன டிசீஸ்க்கும் அதே தானே, இதுக்கு 2 weeks. சரி, ஆவரேஜாக போட்டு வைப்போம். வைரல் டிசீஸ்னால் ஒரு 3 நாள், இந்த டிசீஸ்னால் ஒரு 2 வாரம், அப்படி தானே போட்டு எழுதுகிறோம். ஸோ தட் ஐ டோன்ட் வாண்ட் டு, பட் யூ ஹவ் டு see these are the SOPs given by the WHO or National Center for Disease Control for different diseases. So these again are for people who are practicing or who are in the system or who are not in the system, but for notification or for suspecting. Okay, leptospirosis, these are the common diseases which are giving rise to fevers: cholera, enteric fever, then diphtheria, acute viral hepatitis, measles, chickenpox, chikungunya, Japanese encephalitis, mumps. Recently there are a lot of mumps outbreaks are happening throughout Tamil Nadu. Okay, what are the complications of mumps? Already people are marrying late. There is strong evidence that even though there is no arthritis, but the seminal or other analysis says people are becoming infertile. Okay, so we have to, what as a doctor, what we have to do? As a public health physician, what we have to do? As a doctor, we have to suspect and send the patient for diagnosis, or some sample should be sent. As a public health physician, we have to do a public health response, we have to notify, we have to inform, we have to evoke a public health response. So what will result after public health response? What is the vaccine which is not given by government sector? Mumps, there is no vaccine. Now after experiencing a lot of mumps cases, now the government will think about vaccinating, because in private they are giving vaccines which is called as MMR, measles, mumps, rubella. Government is giving only measles and rubella. So with so many cases, now we will have a thought. I told you initially there will be expert, because people before gathering I was telling you that there are many physicians who are into the system, whether they are from private or from government. They are made as experts, or they are called for the expertise to the committees to form SOPs, to form to formulate policies. So similarly, probably in future, near future, some experts will come and say that mumps vaccine is mandatory and it should be given by the government. But because particularly in this year, a lot of mumps cases have been reported. How clinician contributes to public health strategies or policies? A few simple questions, sample questions answered are to ponder. What impact will these are again few examples I have just taken from a WHO manual. What impact will pneumococcal conjugate and Hib vaccine programs have on the causes of ARI, and thus current algorithms for the management of pneumonia? Because earlier we used to have a lot of pneumonia. We used to study we used to give cotrimoxazole, plenty of cotrimoxazole for ARI. We even have an estimated calculation that children under 5 years will have 3 episodes of ARI, and for each episodes of ARI they will be getting 5 days of cotrimoxazole, and those number of persons less than infants will have 3 episodes. For them we have to give a certain dosage, and we have to indent, and we have to stock the tablets. So this is how suppose for example diarrhea, under 5 year a child will get 3 times diarrhea, and each diarrheal episode will require 2 ORS, and so we have to calculate how many children are there. Probably 10% of the population is under 5. Suppose if there are 10,000 population, then there will be 1,000 under 5 people. For those all 1,000 children will have 2 diarrheal episodes per year, or 3 diarrheal episodes per year, and so 3 into 2, 6 ORS packets for each child. So they will stock 6,000 ORS. This is how the government works. Like any in a private clinic, suppose if I am seeing 200 patients per day, I have to, suppose if I am giving injections to all the 200 patients, I have to stock 200 syringes per day. This is how. So similarly, there are many questions which can be used for formulating strategies, vaccinations, SOPs, etc., etc. So for example, to prevent diarrhea, these questions gave an answer that access to safe drinking water, use of improved sanitation, hand washing with soap, exclusive breastfeeding for the first 6 months of life, good personal and food hygiene, health education, about how infection spread, rotavirus vaccination was introduced in 2006. So this is an integrated health information platform where you can notify the diseases. So if you open the portal, you enter your user ID password, you just notify the diseases. And integrated disease surveillance gives you the flexibility of only notifying the syndromes, suspected, probable, confirmed. And this will be a tool for identifying impending outbreaks. Diseases of international concern, for just to cite a few: COVID-19, cholera, yellow fever, polio, Ebola, Nipah, Zika, etc. Now latest Mpox. And the program is not only for non-communicable disease, also for non-communicable disease, burden-based, and here too we have SOPs, and all SOPs are in place from primary to tertiary care. So there are many diseases, there are many programs for the different diseases, and this is one disease for anemia, this intervention, 6 into 6 into 6. All the nowadays the NEET questions are many questions are based on programs. Okay, what is 6 into 6 into 6? 6 strategies, 6 interventions, 6 institutional mechanisms. Okay, very good, you know about this. So there is one concept called One Health approach. This One Health approach, we have an evidence that Rift Valley fever was managed by One Health approach. Now WHO has declared Mpox as international public health emergency of international concern, similar to COVID. I gave in the first slide I told you that COVID-19. Now it is Mpox from 14th August 2024. Mpox screening has started on Trichy Airport. Mutual collaboration, health seeking behavior is more towards private. IMA, IAP, FOXY, etc. We succeeded in COVID control with all clinicians by prompt notification and case management. Again, I am saying that public health is not government only. Smallpox eradication with the involvement of all public health, private clinicians, other health workers. 1980 we eradicated, we stopped vaccine. Maternal and neonatal tetanus elimination was eliminated in 2016. Poliovirus type 2 was certified to be eradicated in 2015. Poliovirus certification for all polio is 2019. So silo, public health is not silos, silo into synergy. There is a One Health approach, and embrace diversity in approaches. So we have different approaches, we have to think globally, act locally. Thank you.
Thank you, Somasundaram, for the very elaborate and public health, in the public health lens, how we have to approach any diseases, how to notify, and what is the significance, and how to prevent it in the course of the things. Thank you so much. Now I invite, please stay on this. I invite Dr. Sheikh Mohammed, retired Professor of Medicine from Madurai Medical College, and Dr. Asiya Begum, retired Medical Officer from Periyakulam, to honor the speaker.
Thank you, friends. Now it is the most pleasurable moment, and let us have the important program of the function, honoring of the teachers. It's really a great moment, and I first of all extend a warm welcome to our teachers, Dr. Kodiswaran sir, who is a renowned dermatologist in Madurai, and Dr. Nagaratnam madam, who is a retired professor of obstetric and gynecology. And I request both of them to come over to the stage. Now may I request President Alumni Association, Dr. Tamil Selvi, followed by Rubitinum Chairman, Dr. Alagappan, Secretary Rubitinum, Dr. Xavier, and Treasurer Rubitinum, Dr. Sundar. Over to the stage. Now I request Rubitinum Chairman, Dr. Alagappan, to deliver the welcome address.
Good afternoon, everybody. First of all, I welcome our teachers, Professor Dr. Kodiswaran sir. He has been a dermatologist ever since we have entered this Madurai Medical College and GOVT.RAJAJI Hospital in 1984, and so it's our pleasure, and I welcome you, sir. And I welcome Professor Dr. Nagaratnam madam, who was Chief of Obstetrics and Gynecology during when Madam AL was the HOD during our final year. We welcome you, ma'am. It gives me great pleasure as Rubitinum Chairman to honor our teachers, and for the sake of our teachers, sir, we are from 1984 batch, Viludugal 84, and we are conducting this Rubitinum 2024. We entered Madurai Medical College in 1984, so this is 70th year, and 40th year, and Madurai Medical College was inaugurated in 1954 August. So this is the 70th year. So Ruby 40 and Platinum. So we have named it Rubitinum 2024. And as a part of this grand alumni fest, we will be conducting on 14th and 15th of December in a grand manner. So running towards that, we thought of conducting a series of CMEs, and this has been the 7th CME. Every month we have been conducting CMEs, and every month we have been honoring our teachers, starting from Professor Dr. R. Alagappan sir, Muthusamy sir, and all doyens of Madurai Medical College and who have been our teachers. So on this, we are fortunate, and we feel privileged to honor Professor Kodiswaran sir and Nagaratnam sir. Now I request Dr. Sumadi, Sumadi, to talk about sir.
Good morning, sir. Dr. Kodiswaran sir, he was a teacher and leading dermatologist, and he worked and retired as a professor of the head of the dermatology in 1999, and he did MBBS in Madurai Medical College and at 61 to 67, and during the 70 to 71, and he did diploma in dermatology at Madras Medical College, and he did MD dermatology at Madras Medical College, and first posting as assistant professor in Madurai Medical College in the Department of Dermatology, and was working as a professor of head of the Department of Dermatology and retired as a professor of the Department of Dermatology during 1999. And he was a leading dermatologist. In those days, எந்த பேஷண்ட்டை கேட்டாலும் சார் பேரை தான் சொல்லுவாங்க. அப்போ டெர்மட்டாலஜிஸ்ட்னா சார் பேரை தவிர வேறு யாருக்குமே தெரியாது. கோட்டீஸ்வரன் சார் தான் டோக்கன் நம்பர் எங்கேயோ போகும் ப்ராக்டிஸில். நானே சார்கிட்ட ஒரு தடவை பேஷண்ட்டாக போயிருக்கேன். அப்போ தான் அவ்வளோ க்ரௌட் இருக்கும். சரௌண்டிங் வில்லேஜஸ் எங்கே போனாலும் டெர்மட்டாலஜிஸ்ட், எந்த டெர்மட்டாலஜிஸ்ட்னால் சார் பேர் மட்டும்தான் எல்லாரும் சொல்லுவாங்க. அந்த அளவுக்கு சார் was a leading dermatologist in those days. I welcome you, sir, in the behalf of the 1984ians family. Thank you.
Now, honoring of Professor Doc. Now, let me request Dr. Tamil Selvi to say a few words about our Nagaratna madam.
Good morning again. And Nagaratna madam is very close to my heart. I am a direct student of madam. I finished my diploma in DGO in Madurai Medical College. I am an alumni of Madurai Medical College undergraduation and diploma here. And madam, at that time, madam is a third unit chief. And among all chiefs, we love madam like anything. Because madam is so kind. He never scolds us. Always with the kind words only, madam advises to us. Madam is born in a small village near Aruppukkottai. The first among the 5 siblings. Madam was motivated by her father to pursue medicine from a tender age. At the age of 18, she joined Madurai Medical College as part of the 58 batch. I think it is the 4th batch. 5th batch. Madam completed her MBBS in 64 and she joined service right after graduation. Madam got married to Kandasamy sir, general surgeon, belonging to the first 50 batch of Madurai Medical College. Having 3 children of her own didn't stop her from pursuing her post-graduation after a long hiatus in obstetric and gynecology from the same institution with the motivation and support from her family. She rose above the ranks from the postgraduate in 1974 to the head of the department at 1997. ஆக்சுவலாக எனக்கு ஒரு இன்சிடென்ட்ஸ் ஞாபகம் வருது. ஒரு பிஜி லீவ் எடுத்துட்டாங்க. த அசிஸ்டன்ட் இஸ் டெல்லிங் மேடம் தட் ஷி வென்ட் ஃபார் லீவ் அண்ட் இப்படியெல்லாம் லீவ் எடுக்கக்கூடாது, பிஜியாக இருந்தால் லீவே எடுக்கக்கூடாது அப்போ அந்த காலத்தில். ஸோ மேடம் ஆஸ்ட் வை, இல்லை மேடம் ஏதோ அக்காவுக்கு கல்யாணம்னு சொல்லிட்டு இருக்காங்க. அக்காவுக்கு கல்யாணம் போக தானமா வேணும் அப்படின்னு சொல்லிட்டாங்க. ஸோ இன் தட் வே மேடம் இஸ் வெரி கைண்ட் டு அஸ் and madam devoted her 1/3 of her life in the service to patients. And madam is an enthusiastic academician for undergraduates and postgraduates. Madam devoted much of her life to the OG department of Rajaji Hospital, from where she retired as a head of the department in 1997. Post retirement, and madam channeled her energy into traveling many countries and continents across the globe. And we know madam, and everyone knows that madam still maintains a rigorous routine, getting up 6 a.m. Madam still drives the car. இப்போதான் கொஞ்ச நாளாக ஓட்டலன்னு சொன்னாங்க. எங்கே வந்தாலும் anybody who call for help on the table in the middle of the night, madam goes and help everyone. And she remains the inspiration to all the Ojicians, especially to me madam. You are very close to my heart and I am feeling so proud to stand here to welcome you. And thanks for accepting our invitation and coming here to accept this honor from us. Thank you, madam.
Thank you, both of you. Now the important event of honoring our teachers.
We invite all 84ians onto the stage to honor our speakers. Thank you, madam. Thank you, sir. Actually, we cherish these moments in each and every month. I love to come to Madurai every month and to cherish these moments. Actually, so many things money can't buy in life. That's what I feel. And I request Kodiswaran sir to speak a few words among us.
Dear colleagues, I am very much honored by your action, by your activities. Dr. Alagappan has been kind to me. I don't know what to say, but I wish all of you to become good doctors and serve the people better. Thank you.
Good morning to everybody. Good morning, Tana. Afternoon, night. I'm really delighted to see you all in this particular function. I thank all of you, and especially the organizers, for giving me this opportunity to meet you all in this function and for honoring me. I wish you all the very best in life, in all aspects. Thank you all again.
Thank you, sir. Thank you, madam.
So though we want this moment to be endless, we have to come to an end for that. So now I request Rubitinum Secretary Dr. Xavier to say a vote of thanks.
அனைவருக்கும் வணக்கம். ப்ரொஃபஸர் கோட்டீஸ்வர சார் பற்றி நான் ஒரு வாரம் சொல்லிக்கிறேன். நான் ஹவுஸ் சர்ஜன் பண்ணுறப்ப எனக்கு 4 நாள் தான் போஸ்டிங் போட்டிருந்தாங்க. அது வெள்ளி, சனி, ஞாயிறு, திங்கள் இருந்துச்சு. அதில் சனி ஞாயிறு நடுவில் போயிடுச்சு. அதனால் வெள்ளிக்கிழமை ஒரு மதியானம் போல் போய் அவர்கிட்ட ரிப்போர்ட் பண்ணேன். இன்னும் இவ்வளோ லேட்டாக வரேன்னாரு சார். இல்லை சார், லேட் ஆகிடுச்சு அப்படின்னு. அடுத்து திங்கக்கிழமை சாயந்தரமாக போய் சார்கிட்ட ரிலீவ் வந்ததே இல்லையே, நடுவில் சனி ஞாயிறு வந்துருச்சு சார். ஆனாலும் எனக்கு சார் ஒன்றுமே எக்ஸ்டென்ஷன்லாம் கொடுக்காம கையெழுத்து போட்டு கொடுத்தாரு. அதுக்காண்டி இப்போ தேங்க்யூ சார். மேடத்தை பற்றி சொல்லணும்னா, மேடத்தோட ஹஸ்பண்ட் கந்தசாமி சார் வந்து எங்கள் அப்பாவோட கிளாஸ்மேட்டு, ஃபஸ்ட் 50. டாக்டர் அன்பராஜோட பையன் மேடம். நான் எங்களோட அழைப்பை ஏற்று இங்கே வந்து சிறப்பி தந்த கோடீஸ்வரன் சாருக்கும் நாகரத்ன மேடம் அவர்களுக்கும் ரூபிட்டினம் சார்பாக நன்றியை கூறி விடைபெறுகிறேன். வணக்கம்.
Thank you, Xavier. May I request our teachers to
Now we move on to the next topic by Dr. K.S. Ravishankar. It is an update on what is new in psychiatry, and Dr. K.S. Ravishankar is a proud alumni of 1984 batch again, professor and head of Department of Psychiatry, Government Mohan Kumara Mangalam Medical College, Salem, and he finished his diploma in psychiatry between 92-94 and MD from 94-97. So immediately after the undergraduation, he finished both things. And work experience till date, he is in the government service and also in the private sector in Salem, and teaching the undergraduate and postgraduate students till date. And best doctor award from the district collectorate is conferred on him, and has published many papers in the indexed national journals, and he is the president of Salem Psychiatric Club. Actually, I always wonder the people who are taking up psychiatry, actually it is a big எனக்கு ஒரு பெரிய வியப்பு. I appreciate it, KSR. Areas of interest are psychotic disorders, psychopharmacology, and de-addiction. Over to K.S. Ravishankar.
Thank you for the kind words, Tamil. Very good afternoon to you all. At the outset, I thank the organizers for giving me this opportunity. As Soms said, my passion was, I did my special training in surgery and orthopedics, but I was forced to take psychiatry. But no regrets, psychiatry is doing good to me and I am doing good to psychiatry. And moreover, initially my topic I sent was current trends in the management of major mental illnesses. Then there is a slight change or modification in my topic to make it more interesting. What is new in psychiatry? An update. A brief outline of my presentation. First I will talk about the classification, then about the psychotropic medications, the neuromodulation, psychotherapies, and digital psychiatry. To recall, psychiatry is a branch of medicine that deals with the causation, prevention, diagnosis, and treatment of mental and behavioral disorders. The simplest way to conceptualize a psychiatric disorder is as a disturbance of cognition, cognition, and affect. These are the basic functions of mind. The three basic functions are cognition, that is thinking; cognition, activity, we all do some activities, walk, like that; and affect or emotion. So if thinking is disturbed, it results in thought disorder, that is schizophrenia. If affect is disturbed, or mood, affect or mood, if mood is disturbed, it results in mood disorder, and activity is disorder, it results in catatonia. This is the basic thing. This is the broader classification in psychiatric illnesses, that is psychosis and neurosis. In psychosis, we have presence of hallucination, delusion, and the insight will be absent. Whereas in neurosis, the hallucination will be absent, delusion will be absent, and insight will be present. Some examples are, for psychosis, it's schizophrenia and mania, and all others are neurosis almost, phobic anxiety disorder, panic disorder, generalized anxiety disorder, obsessive compulsive disorder, somatoform disorder, dissociative disorder, and depression. Depression can be a psychotic depression or a neurotic depression. So this is a detailed and systematic classification in psychiatry. This ICD and DSM are very important. Usually for clinical diagnosis, we follow ICD. It is ICD means International Classification of Diseases by WHO, and DSM is Diagnostic and Statistical Manual of Mental Disorders by APA, that is American Psychiatric Association. Or some other classifications are Chinese Classification of Mental Disorders, Latin American Guide for Psychiatric Diagnosis, the Research Domain Criteria by NIMH. But anyhow, all our textbooks are based on DSM, and for clinical purposes we follow ICD. This is the timeline of classification of mental disorders. Actually, ICD was published in the year 1893, but mental disorders were included in ICD in the year 1946. Then came the DSM in 1952, then DSM-2 in 1968, ICD-10 in 1994. When I joined my PG, that is Diploma in Psychological Medicine in 92, ICD, that time only it came. Now it is ICD-11, which was published in the year 2022. So this is currently in use, and DSM is 5. This is the classification of the mental disorders. In ICD-11, chapter 6 deals with the mental behavioral or neurodevelopmental disorders. This is the classification according to ICD-11. So this is the broader classification of psychiatric disorders in ICD-11. If you remember ICD-11, that's enough as of now. There are 5 groups. For the group A deals with the neurodevelopmental disorder. As the child is born and it grows, it experiences various neurodevelopmental disorders. Then the psychosis, that is schizophrenia and bipolar mood disorders. And group B, all the neurotic disorders like anxiety disorders, obsessive disorders, and disorders specifically associated with stress, dissociative disorders, feeding and eating disorders. Whereas in C, we have all the substance related addictive disorders, and D, personality disorders, paraphilic and factitious disorders, and the end of life due to degeneration, neurodegenerations, the patients develop dementia. And miscellaneous mental or behavioral disorders associated with pregnancy, child, that is postpartum psychosis, they are all given under group E, and secondary mental syndromes associated with disorders of diseases. Secondary psychiatric disorders in chronic conditions, medical illness or any other chronic conditions. So what are the new disorders introduced in chapter 6 of the ICD-11? Catatonia and bipolar disorder type 2, and body dysmorphic disorder, olfactory reference disorder, hoarding disorder, excoriation disorder, and hypochondriosis. They are all classified under obsessive or related disorders. And complex post-traumatic stress disorder and prolonged grief disorder and disorders associated with stress. Binge eating disorder and avoidant food intake disorder classified under feeding or eating disorders. And body integrity dysphoria, that is disorders of bodily distress or bodily experience. And internet gaming disorder, it's very popular now. This is classified under disorders due to addictive behaviors, and compulsive sexual behavior and intermittent explosive disorder under impulse control disorders. And premenstrual disorder, dysphoric disorder comes under depressive disorder. These are the new disorders introduced in the ICD-11. And next, moving on to the therapies. There are 3 types of therapies available in psychiatry. The first one is, as we all know, pharmacotherapy, and the neuromodulation techniques or physical therapy, the very popular somatic therapy or electroconvulsive therapy, and other additions are there. And the third one is psychotherapy. This is the timeline of FDA approved antipsychotics. In the year 1950, chlorpromazine was introduced. Then later came in 1959 trifluperazine, 1962 thiaridazine. All these drugs are outdated now. When I joined my PG, risperidone, olanzapine, they were all on the top. Now we use aripiprazole, quetiapine, amisulpride, all those things. Of late, very recently, cariprazine has been introduced. So this is the timeline of FDA approved antipsychotics. And timeline of other psychotropics. Lithium, which is used for as an antimanic drug, this was introduced in the year 1949, and in 1951 imipramine, 1972 fluoxetine, 1996 metazapine, 1955 chlordiazepoxide, and venlafaxine, 1993. Of late, gepirone is the newer drug, but it's not available in Indian market. It's available in US. It has not come to India so far. So these are all some of the popular drugs. I think you all would have heard of these drugs. So this is the broader classification of the drugs used for psychiatric illnesses. The first one is antipsychotics, then comes the antidepressants, mood stabilizers, that is anti-manic drugs, anti-anxiety drugs, sedatives, cognitive enhancers which are used for dementia, and drugs used for the childhood psychiatric problems, autism, ADHD, etc., and drugs used in the de-addiction management. So this is the classification of antipsychotics. At one side we have a typical antipsychotics, on the other side we have atypical antipsychotics. Typical antipsychotics, they are chlorpromazine, thyroidazine, trifluperazine, flupenazine, haloperidol. I think you all would have heard of these drugs, but nowadays they are outdated and we are not using it. But in government hospitals they are providing and we are using for the patients. Typical antipsychotics, since they have extrapyramidal side effects, now we have moved on to atypical antipsychotics. This is the array of atypical antipsychotics. It is clozapine, olanzapine, quetiapine, iloperidone, risperidone, paliperidone, ziprasidone, lurasidone, aripiprazole, brexpiprazole, acinapine, sertindole, zotapine, and cariprazine. A long list of antipsychotics. Of late we are using cariprazine. And other drugs, brexpiprazole and pimavanserin, which is used for Parkinson psychosis in the Parkinsonism, lumateperone, iloterant, and xanomeline. They are US FDA approved but not available in India. The only drug available in this slide is only cariprazine. This drug is very useful in the prodromal stage of schizophrenia. Suppose the patient is not taking the drugs regularly, or if he is poor drug compliance, he is refusing to take tablets, means you can give long-acting injectable antipsychotic injections, which is given usually once in a month. The drug acts for 2 to 4 weeks. Previously only fluphenazine, haloperidol and flupentixol were available, but nowadays risperidone, olanzapine, paliperidone, all even aripiprazole, they are long-acting antipsychotics injections are available, but they are very costly. Our people are not could not afford to buy those drugs. Almost olanzapine costs 1,000 rupees, and risperidone 8,000 rupees, paliperidone 3,000 rupees once in a month. So we are resorting to fluphenazine, flupentixol, and haloperidol injections, which comes around 200 rupees per month. And some of the newer drugs, sublingual dexmedetomidine. In April 2022, dexmedetomidine received approval for agitation associated with schizophrenia or bipolar 1 or 2 disorder. This is a rapidly dissolving film strip. It has to be applied in the tongue. Agitation improves as soon as 20 minutes after administration, but is not available in India. And next we moving on to the classification of antidepressants. The first one is MOA inhibitors. In that we have moclobamide and chlorgyline. They are obsolete. They are not available now. And the next one is tricyclic antidepressants. In that we have noradrenaline and 5-HT reuptake inhibitors. The very popular imipramine, amitriptyline, doxepin, clomipramine. You all will be using it. And tricyclic antidepressants, predominantly norepinephrine reuptake inhibitors, desipramine, nortriptyline, amoxapine, and reboxetine. We are all using these drugs. But nowadays, the preferred antidepressant is SSRIs, that is selective serotonin reuptake inhibitors. In that group, we have fluoxetine, fluoxamine, paroxetine, sertraline, citalopram, and dapaxetine. They are very effective drugs which can be given in the elderly population. And SNRI, we have venlafaxine, desvenlafaxine, and duloxetine. And atypical antidepressants, we have trazodone, mionserine, metazapine, bupropion, tianeptine, amineptine, and atomoxetine. These are all older drugs. And we have newer antidepressants like vilazodone and ortiaxetine. This is available. We are using currently. Esketamine, gepirone, brexanolone, and zuranolone, they are not available, but they are US FDA approved. Recently, dextromethorphan plus bupropion combination has come. dextromethorphan 45 milligrams and bupropion 150 milligram. This is a very good drug. It's a very promising drug for treatment-resistant depression. This was approved for MDD in adults in October 2022. This targets the N-methyl D-aspartate and sigma-1 receptors, a new type of antidepressant. It's administered orally and improves depressive symptoms as early as in first week. As we all know, dextromethorphan is an antitussive, and bupropion is used for smoking cessation programs. And the next drug is endoxifen. This is a selective estrogen receptor modulator called as SERM. It's a protein kinase inhibitor. It's an active metabolite of tamoxin. It's very useful in the bipolar 1 disorder. Now its indications has been extended to personality disorders and impulse control disorders, conduct disorders like that. This is a very effective drug, but the thing is, one tablet costs 100 rupees. Should be given either once a daily or twice daily. Next one is lemborexant. In December 2019, it received approval for insomnia in adults. It's a dual orexin receptor antagonist. It reduces sleep latency and increases maintenance of sleep. It's a very effective drug. There is no rebound insomnia after withdrawal like benzodiazepine, but it's very costly. It's available as 5 milligram and 10 milligram tablets. 5 milligram is 45 rupees and 10 milligram is, it comes around 70-80 rupees. But it's a very good drug. And donepezil transdermal system. In March 2022, the transdermal system was approved for mild, moderate or severe dementia associated with Alzheimer's disease. Usually it's given as 5 milligram per day or 10 milligram per day. The transdermal system is applied to the skin once weekly, and it continuously delivers either 5 milligram or 10 milligram of donepezil daily. And viloxazine, it's an antidepressant. Extended release is made available now. In May 2022, viloxazine received an additional indication, this time for attention deficit and hyperactive disorder in adults. The dosage is 200 milligram to 600 milligram. Viloxazine was previously approved for ADHD in children. This is the first approval of a novel non-stimulant treatment in adults for 20 years. All other drugs are stimulant drugs like methylphenidate, pamolin and all those things. Next, moving on to the designer drugs. What is a designer drug? A designer drug, they are the drugs that are synthesized in labs to mimic the original drug, but with a structural or functional modification so that it avoids the classification under illegal or illicit drug. For example, synthetic cannabinoids, cannabidiol, they are used for generalized anxiety and as well as refractory seizures. It's a promising drug, but it's very costly, 10,000 rupees per bottle. And other psychedelics, phenylethylamine, tryptamine and lysergamides. These are the designer drugs. And nutraceuticals in psychiatry, some of the food components are active principles that are present that have positive effects for health and prevention of treating disorders. They are omega-3 fatty acids, vitamin B, vitamin D, choline, iron, zinc, magnesium, SAM, that is acidinosyl methionine, and amino acids. They are useful as an adjuvant in the treatment of depression. Next, moving on to the neuromodulation techniques. In 1930, the popular electroconvulsive therapy was introduced by Serliti and Binney, and in transcranial direct current stimulation, these electrodes are placed on the head, that is used for refractory hallucinations and depression. In the introduced in the year 1960, then deep brain stimulation in the year 2002, 2005, then transcranial magnetic stimulation in the year 1990, vagal nerve stimulation in 2005, magnetic seizure therapy in the year 2001, and the intermittent theta burst stimulation, that is one type of transcranial magnetic stimulation, TMS. It was introduced in the year 2018. And PRISM for PTSD self neuromodulation device approved in 2024. These are some of the neuromodulation techniques. So what is neuromodulation? the alteration or modulation of a nerve activity by delivering electrical or pharmaceutical agents directly to a target area. Either apply electrical or magnetic fields transcranially or involve the surgical implantation of the electrodes. The invasive methods, surgical techniques or implanted cortical stimulator, deep brain stimulation and vagal nerve stimulation. Whereas in the transcranial techniques, the non-invasive techniques, cranial electrical stimulation, ECT, then transcranial direct current stimulation, transcranial magnetic stimulation and magnetic seizure therapy. These are not very effective. Anyhow, some psychiatrists are using it, but electroconvulsive therapy is a wonderful treatment to treat psychosis. TDCS is very cost effective. The machine costs only 8,000 rupees. Even the patients can themselves apply TDCS, but whereas transcranial magnetic stimulation costs from 40 lakhs to 2 crores. But it's not a very promising technique for depression. So electroconvulsive therapy, this was described by Hugo Serliti and Lucio Bini in 1938. It applied electrical stimulates, create electrical field around excitable brain tissue which depolarize cell membranes of the neurons synchronously. Either it can be a unilateral ECT or a bilateral ECT. Two forms of ECT is available. There is one is sine wave and brief pulse. Sine wave is outdated now. When we were doing PG, we used to only sine wave. Nowadays, brief pulse ECT has come, which prevents memory disturbance. There is no much memory disturbance when compared to the sine wave ECT. The indications for ECT are high suicidal intent with major depressive disorder. It's used in catatonia. If the patient is violent or aggressive, in mania, if there is no response or failure to tolerate adverse effect, we can give ECT. If there is only partial response with drugs, we can give ECT. If there is delayed onset of response, and it's very preferred choice of therapy in old age due to unwanted drug interactions or side effects, we can very well administer ECT for patients, geriatric patients, and as well as in pregnancy. And for intractable seizures also we are using ECT. And delirium, Parkinson disease, phantom limb, twilight states, these are the indications for ECT. These are some of the techniques. For essential tremor and tremor dominant Parkinson disease, they are giving focused ultrasound therapy. For essential tremor, Parkinson disease, dystonia, OCD and epilepsy, they are giving deep brain stimulation. For major depression and OCD, they are giving transcranial magnetic stimulation. And listening or ablation therapy is given for laser therapy, for thalamotomy, for tremor, and pallidotomy for dystonia. These are some of the surgical techniques. And next, moving on to the vagal nerve stimulation. Usually vagal nerve has a direct and indirect connections to a group of neurons that are involved in emotional and cognitive functions. It's invasive and non-invasive vagus nerve stimulation are done. Electrical impulses transmitted via the vagus nerve to the brain can relieve symptoms of depression. Refractory depression, they are giving vagal nerve stimulation. And dementia, schizophrenia and somatoform disorders. These are newer RTMS approaches. These are some of the types of transcranial magnetic stimulation, that is theta burst stimulation, prolonged intermittent TBS, accelerated TMS, deep TMS, priming TMS, synchronized TMS. These are some of the techniques used in transcranial magnetic stimulation. And even in trigeminal nerve stimulation or external trigeminal nerve stimulation as a non-invasive and non-medication therapy for ADHD, they are now using it. It's approved in the United States by the FDA for the treatment of ADHD in children ages between 7 and 12. It's also used off-label to treat ADHD in adults. So trigeminal nerve stimulation is one of the choice to treat ADHD. A neurostimulation device. FDA has cleared Modius Trust, a transdermal home use neurostimulation device to treat the symptoms of generalized anxiety disorder in adults. aged 22 years and older. Next, moving on to the timeline of psychotherapy. Psychotherapy was psychoanalysis. It was founded by Sigmund Freud in 1890. Then behavior therapy by Skinner in 1920. In 1950, rational emotive behavior therapy by Albert Ellis. In 1960, CBT came, the very popular CBT, cognitive behavior therapy by Aaron Beck. Then came the dialectical behavior therapy in 1970. Then acceptance and commitment therapy by Stephen Hayes. Mindfulness-based therapy by Segan Williams in 2002. So what is psychotherapy? Psychotherapy refers to a variety of treatment that aim to help a person identify and change troubling emotions, thoughts and behaviors. Counseling is not equal to psychotherapy. It can be used as alternative or along with medication. It identifies ways to cope with stress and develop problem solving strategies. It's not equal to counsel therapy, it's something more than that. So in psychotherapy we have 3 waves. Waves means like we had a corona, first wave, second wave, third wave. The wave refers to an era or generation, first generation, second generation, like that. So in first wave it was, they were more focus was change in behavior, that is behavior therapy. In second wave it was to change the cognition or now our negative thoughts into positive ones, that is cognitive therapy or cognitive behavior therapy. And the third wave behavior therapy, currently it's being used. First one was change in behavior, the second was one was change in thoughts, and the third one was acceptance and commitment. Nowadays we are using mindfulness based approaches to treat obsessive compulsive disorder. So these are the behavior therapies. Now there are 3 waves, the third wave is going on now. Next, moving on to the last one, digital psychiatry. This is a growing field that uses a variety of technologies and approaches to mental health. First one is digital phenotyping. It is capturing sensor data that involves personal as well as biometric information, like the day-to-day activities of a person with the help of gadgets such as desktops, mobiles, tablets, phones, smartwatches, etc. help in monitoring the patterns of thinking, sleep cycles or behaviors that are critical factors for the diagnosis of mental health disorders. Glass Act. It's a project that uses smart glasses by Google to capture the facial expressions and provide social cues in treating the autistic children. Next, cognitive behavioral therapy apps. CBT, iCoach, Mood Coach, and Moving Forward are some of the therapies to help a person deal with and overcome mental health problems. And mental health applications are there. BetterHelp, Talkspace app help in live consultations with licensed, trained, and experienced therapies. Even artificial intelligence is also being used in the psychiatry for early detection from digital phenotyping, in suicide prevention, for as a form of virtual therapist, and remote monitoring of mental health and natural language processing. This is avatar therapy. Avatar therapy is a relational and dialogic approach that involves a 3-way conversation between a therapist, patient, and a computer-generated digital simulation of a patient's hallucinated voice. This therapy is used to help people with psychosis or schizophrenia cope with the distressing voices they experience, combat with auditory hallucinations. Next one is virtual reality experience, which is used in phobic anxiety disorders. It involves virtual reality to simulate different scenarios. VR has been applied for the delivery of exposure-based treatments, whereby individuals can experience the feared situations or contexts in a safe and controlled manner without leaving the clinical setting. If anything happens to them, we can immediately intervene. And this is for sensory integration therapy, and this room is called the Snoozland room. It's very useful in autism, ADHD, dementia, and brain injury. And these are some of the mental health apps you can download from the App Store or Google Play Store. Endeavor app used to treat ADHD, and Nightwear to treat PTSD. Reset-O aids in the treatment of substance use disorders, and Somrest used to treat insomnia, and Rejoin to treat depression. This is the app Rejoy. Nightwear, Endeavor, Reset, Somrist. These are some of the apps available in the App Store. The next one is Telepsychiatry, Telemenas, or Tele Mental Health Assistant Networking across. This is the initiative of Tamil Nadu, and it is available as a toll-free 24/7 helpline. You can call 14416 for free mental health counseling or any help. And one more thing is Manam. Manam means Mananala Naladaravu Mandram. I think all the UG students and PG students will be aware of. It's a Tamil Nadu government initiative. This is for, actually it has been extended to other arts colleges also. Nowadays we are regularly conducting Manam meetings and reporting to the NHM National Health Mission. So in summary, pharmacological treatment is the mainstay of management, and definitely ECT remains as a gold standard treatment in resistant cases and acute settings. There is a paradigm shift from functional to biological basis of illness, and protecting the rights of persons with mental illness is emphasized in the Mental Health Care Act, that is 2017. Thank you.
Thank you, Ravishankar, for finishing in time actually. Thank you so much. And I invite Dr. Adagarsamy and Dr. Anandi to honor the speaker on the stage. Now moving on to the most awaited quiz.
Now next we are going to have a radiology quiz, which was supposed to be held in last CME, but because the final year and pre-final students couldn't attend, so we moved to this side. Now we asked for because radiology is a postgraduate subject, I don't know how far you will be able to. So students, they requested to form teams of 2, and there are some 10 teams who have already formed. So you can either attend as a team of 2, or you can attend, all of you can attend. You are given a paper. There are 40 questions, and there will be no conflict of interest for quiz master. Total number of questions are 40. Each question having 2 questions. For each correct answer, there is 1 mark. And if 2 answers are correct, 2 marks are awarded. No negative marks. Time for each quiz is 40 seconds. 40 seconds, the images will flash on the screen. Then it will move on to next slide. And it's mandated to switch off participants' mobile and all electronic gadgets. Quizmaster decision is final. And now we move on to, now I introduce Professor Dr. Sundarajan, who is a very proud alumni, and he is a professor and head of the department, Meenakshi Medical College in Kanjipuram, and he was the organizing secretary of the last Radiology CME, which had the maximum attendance so far. We had around 290 attendees, including students. So Sundarajan has served in several fields across the breadth and width of country, starting from east to west, north to south, and he has worked in all modalities. Had he was had he been he was working in Madurai Medical College. Had he continued in Madurai Medical College, he would have been head of the department for so long now. And over to Sundar Rajan now.
Thank you very much, Alagappan. Good afternoon, one and all. See, just I want to highlight only one point here. Each quiz having two questions. The purpose behind having two questions is, you will be surprised to see these images. Each question will be acting as a clue for the diagnosis. Sometimes the first question will act as a clue for the second question. Sometimes the second question's answer may be the clue for the first questions. So watch it carefully. Okay, let us start our quiz. Okay. Next slide. नहीं बनेगा. Forty seconds. If you know the second question, then you will answer the first question. I'll announce that. Check. Now the timing has been reduced to 30 seconds per slide. 30 seconds. Two questions are there. if you know the diagnosis, you can answer the appearance. If you know the appearance, you can diagnose the pathway. Physicians can try. என்னப்பா சேஞ்ச் ஆயிருக்கா? இப்போ சேஞ்ச் ஆயிருக்காங்க. See, if you know the syndrome, you can know the diagnosis. டாக்டர் ஒரு மீட்டிங்கில் இருக்கேன் டாக்டர். Again, very interesting case for the physicians. Physicians. It is a case for physicians. தெரியல, என்னன்னு தெரியல. முடிஞ்சிடும், இன்னும் ஒரு 5 இருக்கு. வந்துச்சு. answers. மூணு ஸ்லைட் இருக்கு. தியரியாக பார்த்து இது நான் படத்தை பார்த்தேன் குழுன்றது என்ன தியரி ஆன்டி டிப்ரெஷன் எனக்கு மாத்திரை மருந்து அது கேட்பாங்க. டாபிக் போட்டால் இன்ட்ரெஸ்டிங்காக இருக்காங்க. ஃபஸ்ட் ப்ரைஸ் 3000 2000 1000 சரியா கூட வந்துச்சுன்னா அடிஷனலாக கொடுத்துருவோம். சரி சரி ஜாயின் தர மாதிரி வச்சுன்னா சரி நான் இது டைப் ரெக்கர் மாதிரி வச்சுருக்கேன் கொஸ்டினை சரி டைப் ரெக்கர் எல்லாமே நல்ல கொஸ்டின் தானே பேசினா தான் கேட்குங்களா. So if you know the deformity, you will know the diagnosis. எல்லா கிலோ நான் தான் நேற்று சொன்னேன் ஒரு நாளே முடியாது அப்படின்னு. ஆனால் ஈஸியாக தான் இருக்கும். Fine, we get to the last case. This is the last case. காசு கேட்குறேன் கொடுக்க மாட்டேங்க. அவங்க தான் See, all the PGs are requested to write their name and mobile in their answer sheet and hand over the answer sheet. This is the last slide.
By the time we collect the papers and we correct the this thing, we'll move on to the next and last topic for the day. A discussion of interesting cases by Professor Sivakumar.
Can we start? Students, please. Yes, thank you. These are all some of the real case scenarios presented in physicians meets of my college and hospital. So I am going to give 2 slides and the investigations, and you can name the disease. So I have taken 10 cases. Paakalam time with the availability of Alagappan's permission, how far we can go through paapom. No, அது வந்து இது ஒன்றும் இல்லை, சின்னது. 17 years old female pursuing 12th grade presented to emergency department with the complaining of breathing difficulty for the past 1 week, referred from Nilgiris as a case of viral pneumonia for further management. Patient was dyspneic, tachypneic with the saturation room air 73%, and an invasive ventilation was started and history was probed. Patient complained of headache intermittent for the past 2 months and appearance of multiple rashes over the body along with painless oral multiple ulcers. CT chest revealed bilateral patchy ground glass opacities involving lower lobes with other blood investigation suggestive of significant pancytopenia. Right. So the clue: she is a female, 17 years, breathing difficulty, headache, rashes all over the body, then painless multiple ulcers and a respiratory involvement in the form of ground glass opacities, and the blood investigation suggestive of pancytopenia. So yara orthar சொல்லுங்க. சொல்லுப்பா, இல்லை நானே கூப்பிட்றதா? தம்பி, கண்ணாடிக்கார தம்பி எந்திரிங்க. இல்லை, நான் அப்படித்தான் கூப்பிடுவேன். சட்டை போடுற தம்பி, வெள்ளை சட்டை போட்டிருந்தா வெள்ளை சட்டைக்கார தம்பி, ஃபர்ஸ்ட் ரோ. சொல்லுப்பா. See, don't worry. See, this is how we learned. What are the possibilities? Yes, very good. Give him a hand. Sir, applause. Yes, although she met the diagnosis of diagnostic criteria for SLE in all investigation were done to rule out infectivitis. If whatever may be, the first thing in any அது வந்து இந்தியாவாக இருந்தாலும் சரி, சைனாவாக இருந்தாலும் சரி, அமெரிக்காவாக இருந்தாலும் இன்ஃபெக்ஷன் ஹேஸ் டு பி ரூல்ட் அவுட். Then we started suggestive of an acute lupus pneumonitis with evolving SLA. This is the working diagnosis. I think patient recovered and she is on follow-up with the rheumatology OP as of now. Thank you, Pa. So this is the oral, multiple painless oral ulcers. This is the CT picture of ground glass opacities. So ground glass opacity is a new term after COVID epidemic. Subpleural opacities, peribronchial opacities, then both the ways. So these three things pictures. நம்ம இப்போ என்ன பண்ணிடுறோன்னா, எந்த பேஷண்ட் ப்ரீத்திங் டிஃபிகல்ட்டின்னு வர்றவானோ இல்லையோ அவனுக்கு சிடி செஸ்ட் எடுத்துடுறோம் முதல்ல எக்ஸ்ரேக்கு முன்னாடி. தட் ப்ரிவென்ட்ஸ் டூ திங்ஸ். ஒன் இஸ் ரெடியூசிங் த எக்ஸ்ரே ரேடியேஷன் அண்ட் ஆல்சோ வி கேன் ஹேவ் அ டயக்னாஸ்டிக் இது. ஓகே, ஸோ திஸ் இஸ் ஹவ் யூ ஹேவ் டு ஒர்க் இன் ஹவுஸ் சர்ஜன்சி. டோன்ட் வேஸ்ட், டேக் எக்ஸ்ரே தென் அதெல்லாம் வேணவே வேணாம். When the facilities available, go for a high-end model. Then coming to the case 2, 45-year-old male, low economic status, presented with complaints of low-grade fever, sweating, weight loss, and loss of appetite for the past 1 month, present to the hospital with the chief complaints of weakness of right upper limb and lower limb, along with altered mental status for the past 1 week. Investigations were proceeded with yielded a cobweb appearance. இது எதுக்கு இந்த பேஜ் இந்த மாதிரி போட்டா அப்படின்னு தெரியல, ஆனால் போட்டுருச்சு. Cobweb appearance of CSF and elevated proteins, and a CT brain showed an acute lacunar infarct in vermis with CT chest showing miliary pattern of tuberculosis. So what's the diagnosis? It's obvious. என்ன diagnosis? TB. இன்னும் ரிஃபைன் பண்ணுங்களேன். disseminated TB. see இங்கே வந்துருச்சு அப்புறம் இதை தவிர்த்து வேணா இருக்கு. சரிங்களா? ஸோ எஸ், ஸோ diagnosis, a case of neurotuberculosis with end arthritis. So TB brain, 3 types you can get. One is meningitis, another one is tuberculoma, another one is arthritis. So in the patient infarct vandadukku reason neurotuberculosis with end arthritis sequelae in a miliary tuberculosis patient. Patient was started on ATT and improved in due course of time, and it is followed with GH in steroid along with the steroid therapy. சரிங்களா? So this is the cobweb appearance of the CSF. cobwebங்கிறது வந்து நூலாம்படைன்னு சொல்லுவாங்க தமிழில். நம்ம வீட்டில் இப்போ நம்ம ஹாஸ்டல்லாம் நூலாம்படை மாதிரி இருக்கும். சரிங்களா? இல்லைன்னா நீ சொன்னோம்னா நம்ம சமையல் ரூமில் கருப்பாக இருக்கும் அந்த இது. ஸோ அதுதான் டிப்பிக்கல். இது ஸ்பெசிஃபிக்காக எடுத்து வச்சது. தெரியுதுங்களா? ரைட். Then the case number 3, 45-year-old female reported to the hospital with weakness of bilateral both lower limbs for the past 3 days with difficulty in passing stools, no history of vomiting, loose stools, or excess carbohydrate meal consumption, or excess sternoval exercise. History of prior similar episodes which was treated then and there. Her blood investigation suggestive of low serum potassium with 2.8 milliequivalents, along with increased urinary potassium and increased serum aldosterone and renin levels with normal cortisol level. So what could be the first diagnosis? Correct. 2.8 motor weakness, ascending paralysis. So hypokalemia and then and there treated. So periodic episodic hypokalemic periodic paralysis. அதுக்கப்புறம் வர்றது தான் காம்ப்ளிகேஷன். இன்க்ரீஸ் சோடியம் பொட்டாசியம் லெவல், சோடியம் ஆல்டோஸ்டிரான் ரெலின், இதெல்லாம் வந்தோம்னா கிட்னி டாக்டர் கூப்பிட்டுருந்தோம். சரிங்களா? தென் த CCT abdomen shows revealed a mass over the right adrenal gland which showed a rapid washout on the contrast administration suggestive of adrenal adenoma. Then patient was treated with potassium sparing diuretics and diagnosed recurrent hypokalemia due to primary hypoaldosteronism, that is Kahn syndrome. So any hypertensive patient with the hypokalemia in ECG changes always suspect Kahn syndrome. So with the radiologist help we diagnosed Kahn syndrome. Okay. Then coming to the case 4, this is an interesting case recently presented. A 39-year-old female who's a known case of rheumatic heart disease, mitral stenosis, post-mitral valve repair done, and also had a cerebrovascular accident, post-mechanical thrombectomy, later developed atrial fibrillation with fast ventricular rate, and was treated with warfarin and amiodarone respectively. Now presented with breathing difficulty and yellowish discoloration of eyes and mucous membrane. Her ECG shows atrial fibrillation with fast ventricular rate. Blood picture revealed elevated liver enzymes with increased TSH and normal renal function. What are the possibilities? Any idea? Papa? நீங்க தான்மா yellow color பாப்பா. சொல்லுமா. No idea. Okay, no issues. So patient on drug. So it is a typical drug related interaction that causes some toxicity. என்னென்ன atrial fibrillationக்கு நம்ம என்ன மெடிசன் கொடுத்துருக்கோம்? amiodarone கொடுத்துருக்கோம். amiodarone can cause hepatotoxicity. amiodarone can cause thyroid dysfunction. சரிங்களா? Now coming to the இது. So the timeline of the patient. 1997 rheumatic heart disease, 2018 developed cerebrovascular accident and developed thrombus, அதுக்கு warfarin. அதுக்கப்புறம் 2021 developed atrial fibrillation with the fast ventricular rate reduce பண்ணுறதுக்கு drug amiodarone கொடுத்தாங்க. 24 also breathing difficulty and jaundice. So rheumatic heart disease, mitral valve repair done, atrial fibrillation, amiodarone induced thyrotoxicosis type 2, supratherapeutic INR results in acetylbromide amiodarone interaction, amiodarone induced liver fibrosis, cardiac cirrhosis. At present the patient drug was amiodarone stop பண்ணிட்டோம், liver enzymes வந்து குறைய ஆரம்பிச்சிருச்சு. For rate control we are using beta blockers. Okay, இது ஏன் யூனிட் பேஷண்ட். So this is the ECG. இல்லை பண்ணியிருக்கு ஹெச்ஆர்சிடியும் பண்ணிட்டோம். ஆக்சுவலி அந்த பேஷண்ட் சிரோசிஸ் மாதிரி போயிடுச்சு, கார்டியாக் சிரோசிஸ் மாதிரி போயிடுச்சு. பட் ஃபாலோஅப்பில் இருக்குது. லங் ஐ திங்க் சிடி செஸ்ட் பண்ணோன்னு நினைக்கிறேன். ஃபைப்ரோசிஸ் இருக்கு. Then case 5, dapsone is an antibiotic used as a multi-drug regimen for leprosy and dermatitis herpetiformis, can lead to dapsone induced hypersensitivity syndrome characteristic by fever, skin rash and multi-organ dysfunction, most probably hepatitis and lymphadenopathy. We have seen a 35-year-old female with borderline lepromatous leprosy, started on dapsone, presented with hospital with severe abdominal pain and yellowish discoloration of eyes. Her blood picture revealed an elevated enzyme with MRCP ruling out cholestasis, diagnosed as a case of dapsone induced fulminant hepatic failure, and the drug is stopped. The patient, despite adequate treatment, the patient died. So இது ஏன் இந்த இது சொல்லணும்னா, sometimes when we intervene our measures can harm the patient, so don't harm the patient with your intervention. That's the message. So this is the pictorial presentation. Okay, so can we continue or I can stop? Okay, thank you for the opportunities.
இல்லை ஃபஸ்ட்டு வரலையா பாயிண்ட் எப்படி கொண்டு வேணாம் செகண்ட்ஸ் வேணாம் இதே பண்ணிக்கலாமா? So it's a J-shaped cella with macrocephaly, thickened calvarium. The only diagnosis is Hurler syndrome. This is mucopolysaccharidosis 1. The clinching point is cellular shape. The clue is given. That is a cellular shape. This is a J-shaped cella. You see the cella here. This is J-shaped cella. The only diagnosis is mucopolysaccharidosis 1, Hurler syndrome. This is second slide. Bone, what is the appearance? This is bone within bone appearance. You see, there is a bone. That lot of sclerosis is there. This is called bone within bone appearance. It's got lot of differential diagnosis, including osteopetrosis, Paget's disease, sickle cell anemia, thalassemia. If any one of the answers are given, its mark will be awarded. Then this is a very interesting case. This is an investigation called MR angiography. MR neuroangiography without contrast. No contrast is used, no interventional procedure, just to put the patient in MRI scanner and do a MR angiography. The diagnosis is occlusion of internal carotid, both supraglenoid segments of both internal carotid artery in a young patient, leading to recurrent stroke. Due to occlusion of both internal carotid artery, there is lot of pile collaterals will produce a puff of smoke appearance. So this is called moya-moya disease. Moya-moya disease is nothing but idiopathic, non-infective, non-inflammatory, non-atherosclerotic, progressive vaso-occlusive disease. So again, this is a case of Strouge-Weber syndrome having tram track-like calcification. This is what is the appearance is tram track-like calcification is highly suggestive of. There's a significant cortical atrophy is there. Sometimes the patient present with the left, if there is a lesion in the left side, the patient may present with right side weakness also. So this is a case of tram track calcification due to Strouge-Weber syndrome. So this is an interesting case. So this is called Chilaty design. This should not be misinterpreted as pneumoperitoneum. Few clinicians used to diagnose this air under the diaphragm and this pneumoperitoneum. This is called Chilaty design. This is a normal variant. That is due to interposition of colon into the liver, between the liver and diaphragm, producing a pseudo pneumoperitoneum appearance. So again, you see the cobra head appearance. You see this is like a cobra head, bilateral cobra head appearance. This is a case of erythrocele. Bilateral erythrocele, most of the time it is a congenital erythrocele, sometimes acquired erythrocele also there due to UV junction dysfunction. So this is again, you see the appearance is like a Christmas tree appearance. See the appearance is like Christmas tree appearance, is highly suggestive of the bladder is like a Christmas tree, and due to neurogenic bladder, there is a chronic outflow obstruction, then there is a trabeculation of bladder mucosa and the bladder is elongated, giving a Christmas tree appearance, highly suggestive of a neurogenic bladder. So again, this is a very interesting case. The patient have a meal. After that, after 2 days, she developed severe neck pain, breathlessness, and all. You see a foreign body here. This is a chicken piece impacted in the cervical esophagus and retropharyngeal abscess with air packets. See, this is the first diagnostic point is you see the prevertebral space widening. How much it is widened? The prevertebral space is widened. There is a foreign body here. This is impacted in the post-cricoid region, and superiorly there is a perforation with producing air pockets and retropharyngeal abscess. This is an emergency condition. And these are two cases. Lateral view showing two different cases. The lateral view showing a broad-based bony outgrowth and medullary cavity is seen continuing with the parent bone. This is a pedunculated bony outgrowth and the medullary cavity is continuous with the parent bone. So this is called sessile osteochondroma. The first one is called sessile osteochondroma. Second one is called pedunculated osteochondroma. Osteochondroma. Even if the If the answers are osteochondroma itself, we can give 1 mark. Okay. So this is again a hysterosalpingography, producing outpouchings of contracts from the fallopian tube, producing a nodular appearance. This is called salpingitis ischemic nodosa. The most common causes in India is tuberculosis. This is called salpingitis ischemica nodosa due to tuberculosis. Most common causes tuberculosis or any other infective etiology. So this is a case post-cholecystectomy patient presented with a recurrent jaundice. This is a investigation is called percutaneous transhepatic biliary drainage catheter is seen, and there is, you see small filling defect here. You see the small filling defect in the common dilated common bile duct. This is a recurrent stones obstructing the common bile duct, producing obstructive jaundice. The GB is not visualized post-operatively. This is called percutaneous PTBD. So this is a angel wing sign or spinnaker sign. This is due to a pediatric case. This is due to pneumomediastinum. This air pneumomediastinum is outlined the thymus. This is called angel wing sign. Next, this is a split pleural sign. The enhancing pleura, there is a fluid in the pleural cavity. It will get loculated. So this is a case of split pleural sign. So you see the parietal pleura, you see the visceral pleura. The pleura is split, and in between that there is a loculated fluid is there. And this is called split pleural sign. It can be due to pulmonary empyema. Even if the answer is pulmonary pleural effusion also, it is correct. Loculated pleural effusion. This is a perium swallow. So you see the appearance is very typical. This is a corkscrew shaped esophagus. This is a corkscrew shaped esophagus due to esophageal spasm. This is not pathological. This is a due to diffuse esophageal spasm. Again, dilated esophagus with retained column of barium and bad beak sign. You see the bad beak sign. This is highly suggestive of achalasia cardia. Another sign will be there in that ratile sign. That is irregular narrowing of the distal esophagus. That is due to malignancy. But smooth narrowing is always called bad beak sign, suggestive of achalasia cardia. Again, I told, so if you know the name of the syndrome, that is called Plummer-Vinson syndrome. Patient presented with anemia, koilonychia, and dysphagia. So the classical triad of Plummer-Vinson syndrome. If you know Plummer-Vinson syndrome, it's a syndrome, you will know the diagnosis, that is esophageal web. There is a web is there. So this is a figure of 3 appearance due to coarctation of aorta. You see the aorta like a figure of 3. It's a aortic coarctation. This is a very simple case. This is a bat wing appearance. Lot of granulous opacities in the perihilar region, like a bat wing distribution. This is the pulmonary edema. So you see the patient is the ICU patient. So supine X-rays we have taken, not posterior anterior view. It is a supine view X-ray. Oh, this is very interesting case. This is a very interesting case. This is a fetogram. What is fetogram? Fetogram means this is a case actually antenatally diagnosed as a case of phocomelia. At 24 weeks of pregnancy, we diagnosed antenatally we diagnosed this as a phocomelia. We aborted the fetus. We took the X-ray of the fetus. That is called fetogram. You see the absent rhizomelic type of phocomelia is there. You see absent forearm is here. This is the X-ray taken in the aborted fetus. You see the umbilical cord is here and absent forearm. See, investigation is called fetogram. This is very simple. Meniscus sign. See the meniscus sign and see the fluid is here. Pleural effusion. So this is again a breast within breast appearance, mammogram. So the diagnosis is breast hamartoma. Breast, you see the outer layer of the breast, and again inner breast is there. This is breast within breast appearance. It is due to breast hamartoma. Again, what is the investigation name of the study? It is magnetic resonance cholangiopancreatography due to pancreatic divisum. Pancreatic divisum is abnormal insertion of main pancreatic duct into minor papilla, that is duct of Santorini into minor papilla. So this will lead to recurrent pancreatitis. This anatomical variant will produce recurrent pancreatitis. So this is rigorous double wall sign. This is outer and inner wall of the bowel is filled with air, and you see the air under the diaphragm. You see some air under the diaphragm. This is case of pneumoperitoneum. This is IVU patient having a drooping lily sign. You see the drooping lily or drooping flower sign. See this patient is having double collecting system, and the upper pole collecting system is obstructed, and it's producing a mass effect over the lower pole collecting system, producing a drooping lily sign. This is duplex collecting system, obstructed upper pole collecting system and drooped out lower pole collecting system. So again, this one of the imaging findings. You see the absence of terminal pharynges. You see this should not be mistaken for acroosteolysis. This is the absence of terminal fingers. You see the medullary cavity is obliterated. There is a lot of sclerosis is there. There is no medullary cavity is there. Cortex and medulla is white, purely white. And the shape of the skull is triangular shaped. You see the frontal bones are like triangular, and it is called trigonocephaly. The diagnosis is pycnodysostiosis. This is stepladder sign, small bowel obstruction. Multiple fluid levels. This is called stepladder sign, small bowel obstruction. See, this is apple core deformity. This is apple core deformity. You see the core apple here. This is a colonic. Any colonic carcinoma or gastric carcinoma, any colonic malignancies or gastrointestinal malignancy will produce a apple core deformity. That apple core deformity is very highly suggestive of a malignancy. So again, sobubble appearance. It's a sobubble appearance, giant cell tumor. This is in coffee bean appearance. You see the coffee bean appearance of dilated sigmoid loop. This is a classical case of sigmoid volvulus. This is patellar tooth sign. You see the new bones are looking like tooth. This is a patellar tooth sign. It is due to degenerative enthesopathy because of chronic overuse or chronic degeneration of the patellar tendon. There is new bone formation is there. This is called degenerative enthesopathy. The sign positive is patellar tooth sign. This is very interesting case. This is a crazy paving appearance or ground glass, multiple ground glass opacities, highly suggestive of a COVID pneumonia. Crazy paving appearance on both lungs, ground glass opacities, multifocal patch areas of ground glass opacities throughout both lung fields. It's a COVID pneumonia. This is a thumb printing sign. There is a air in the bowel wall in a pediatric patient. It's highly suggestive of a pneumatosis intestinalis. That is called necrotizing enterocolitis. So what is sign is thumbprint sign. The diagnosis, the terminology is pneumatosis intestinalis. This is a very interesting case. This is a procedure called lateral invertogram to diagnose a case of imperforate anus. This is a case of anal atresia. We used to put a marker in the anal pit, and you used to put the patient head down and take a X-ray. You know the distance between the dilated rectum and the marker. Then you can diagnose a case of high or low anal atresia. Again, this is called bulging fissure sign. So you see the fissure is getting bulged, and there is a consolidation is there. This case, I think that very much interested for Dr. K.S. Ravishankar. Where is he? Is here or not? He is not here. See, this is a classical case of Klebsiella pneumonia. So, K.S. Ravishankar used to tell Klebsiella kalapittu povadimbaru. Klebsiella pneumonia. Okay. This is again, if you know the deformity, this is called Botanier deformity. It can come in rheumatoid arthritis, that is hyperflexion of the proximal interphalangeal joint and hyperextension of the distal interphalangeal joint. a bottom-head deformity, rheumatoid arthritis. Even it can come in a injury to extensor tendon also will produce a bottom-head deformity. But classically it will be associated with rheumatoid arthritis. So again it is a case of local gigantism. You see the finger here, you see the normal finger, you see the swollen finger. You see how much fingers are swollen, and this finger is also swollen. So this is a case of local gigantism. This is a case of local gigantism involving the metacarpals and phalanges, which appears swollen. This is the increased growth of soft tissue in the left forearm. This is a syndrome called Klippel-Trenaunay syndrome. There are two components of Klippel-Trenaunay syndrome. One is venous malformation, other is soft tissue hypertrophy. This is hypotonic duodenography. We used to give glucagon to reduce the motility of the duodenum, and we used to give oral contrast and take pictures in various views. This is hypotonic duodenography. Diverticulum with a filling defect in the corresponding papilla. This is a diverticulum, duodenal diverticulum. This is an investigation called micturating cystourethrogram to diagnose posterior urethral valve. So this is the bladder, this is the dilated posterior urethra. You see the bladder mucosa is very much thickened. This is a chronic obstruction, dribbling of urine was there, recurrent infection. There is a posterior urethral valve and cystitis. This investigation is called micturating cystourethrogram or voiding cystourethrogram. So this is again called a cavity, a thick-walled cystic cavity containing a rounded soft tissue density opacity here inside the cavity, intracavitary foreign body. So surrounded by air. This is called Monod sign due to a tuberculous cavity is filled with aspergilloma, fungal ball. This is called fungal ball. The sign positive is a Monod sign or air crescent sign. This is a case of aspergilloma complicating the tuberculous cavity. That's all like this.
Thank you, Sundarajan. It is excellent, it is wonderful, it is awesome. It is a great learning for everyone actually. The results will be announced in 3 to 4 minutes. Students, kindly wait for that, and we have lunch and disperse. And we don't have any post-lunch program today. It is a happy news because we don't have one talk. Actually, we are cancelling that. சில பேர் ரொம்ப கவனமாக திருத்துறாங்க, அதனால கொஞ்சம் லேட். ஆமாம், ஸ்ட்ரிக்ட் ப்ரொஃபஸர்ஸ் இருக்காங்க. Actually, let us have Sundarajan. You and SSR, both of you, feed all the questions in the Kahoot. Kahoot is a quiz app. And we will have one postgraduate quiz. Along with that, you make it still more difficult. For the undergraduate sake, you have reduced the difficulty. Okay. But let us have one online quiz for the radiology postgraduates throughout the state by Rubitinum 24 and Virudigal 84. And I asked SSR also. So let us find out. நீங்கள் பிஜி கேடு பண்ணுங்க. அந்த குவிஸ் அந்த ஆப்பில் போட்டுறணும் எல்லாத்தையும். எல்லாரும் லாகின் பண்ணணும். இமீடியட்டாக அந்த ஆப் நமக்கு யார் யார் ஆன்சர் பண்ணுறான்னு சொல்லிகிட்டே இருக்கும். யார் ஃபஸ்ட்டு ஆன்சர் பண்ணுறான்னு கூட சொல்லும். என்னப்பா ரெடியா?
Sundarajan is very, we should thank him for that.
Thank you, Sundarajan, for 38,000. இல்லப்பா
அக்கா எழுதிறீங்களா?
நான் பண்ணேன் மேடம், பிஜிஸ்லாம் பண்ணல, நான் பர்சனலாக பண்ணேன். அலைன் பண்ணது மட்டும் தான் பிஜிஸ் பண்ணேன்.
கொஞ்சம் டிஃபிகல்ட்டா ஒரு குவிஸ் பண்ணி ஒரு கான்ஃபிடென்ஷியலா ஒரு பிஜியை வச்சு லோட் பண்ணுங்க. அவனுக்கு மட்டும் தான் தெரியணும் அந்த குவிஸ் ஆன்சர். அவன் யாருக்கும் லீக் பண்ணிட கூடாது. அந்த கஹூட் ஆப் உன்கிட்ட கேளுங்க, பிஜிக்கு தெரியும். அந்த ஆப்பை பிடிச்சு அதில் லோட் பண்ணி நம்ம ஆன்லைன் வைக்கிறோம் சொல்றீங்க நீங்க.
ரெண்டு பேருக்கு எழுதுனா அப்ப ரெண்டு தனித்தனி சர்டிஃபிகேட் கொடுப்பீங்களா?
ஆமா,
ஆமா கொடுத்துருவோம்.
சரி, அனௌன்ஸ் பண்ணிடுவோம்.
Black ink. Black இல்ல,
இது எழுதுங்க, இது எழுதுங்க, அக்கா இது எழுதும்.
அனௌன்ஸ் பண்ணி.
ஆமா. The first prize goes to Naga Karthik and Muralidharan. Naga Karthik and Muralidharan. ஏங்க ரெண்டு சர்டிஃபிகேட் எழுதுங்க. ரெண்டு எழுதுங்க. யூஸாவே இருக்கு, அதுல 6 இருக்குல்ல. சர்டிஃபிகேட் 6 இருக்கு, நீங்க தானே சொன்னீங்க. ஆமா, இதுல எழுதி
ஃபர்ஸ்ட் எழுதிட்டு கூட அடுத்து செப்பரேட்டா கூட
ரெண்டு எழுதாம அக்கா இப்படி எழுதுறாங்க.
ஐயோ
இப்படி எழுத கூடாதுக்கா.
அது நாலு சர்டிஃபிகேட் வேஸ்ட் ஆயிடுச்சு பாரு.
இல்ல அத
இது எப்படி அவங்க யூஸ் பண்ண முடியாது பாரு. ஏங்க
நாககார்த்திக் மட்டும் எழுதுங்க. அதுக்கு தானக்கா 6 இருக்கு, முதல்ல நீங்க சொன்னீங்க. Second prize goes to Manoj D and Gurucharan N. இந்தாங்கப்பா, ஃபர்ஸ்ட் கொடுங்க. ஃபர்ஸ்ட் கூப்பிட்டு கொடுத்துருங்க. கடைசி ஆளுக்கு சர்டிஃபிகேட் கொடுக்க வேண்டாம், அவ்வளோதான். மனோஜ் ஒரு இதில் எழுதுங்க. Third prize goes to Vignesh R and Netra V. Vignesh R and Netra V. அவங்க சர்டிஃபிகேட் வேண்டாம், வேண்டாம் எழுதாதீங்க. வேண்டாம் வேண்டாம், அங்கே கொடுத்தாச்சு. Naga Karthik and Muralidharan is getting the first prize. Huh? Congratulations, Naga Karthik and Muralidharan. It is awesome, actually. Wonderful. Dr. Gurucharan and Dr. Manoj.
One minute. This Murali, I think this is the 4th quiz he is winning. And Naga Karthik.
Karthik. So congratulations.
Gurucharan and Manoj.
Keep this thing. வா வா நானா நீயே சொல்லு சும்மா தேங்க்யூ சொல்லு.
So we are coming to the conclusion of this grand ceremony. Alumni of Madurai, Dr. Vidya, Director MVR Hospital, for sponsoring this grand event and making it as a wonderful function. Give her a big hand. And I thank all my classmates who always support me in every aspect in life. Then and invited me for giving the topic in my alumni, UG alumni. I thank all the, and I thank Dr. Somasundaram, I thank Dr. Ravi Shankar, and I thank Sundarajan for the conclusion of the quiz and all other things. And I thank all the students who actively participated in the programs. Now we are going to honor Dr. Sundarajan, Professor of Radiology, Meenakshi. And I thank all the organizing team in Madurai and out of Madurai for successful completion of the successful conduct of the CME. And I request all the alumni to participate in enthusiasm in both on the off the record and on the record. Okay. And I thank all the supporting people. I don't know the names and people. So Mr. Peter and their team for their excellent audio visual arrangements. I thank Karanai hospital staff members for their registration activities, and I thank the videographer, and once again videographer as well as the photographer for making the function as a wonderful one. And once again I thank everyone. Kindly don't take it as a mistake. If I missed anyone, kindly include them also in the Thanksgiving ceremony. Okay, then we can come to a conclusion. I request everyone to go for a lunch. The lunch is available outside. Thank you. Thank you.